Hi, morning, dear. Have you gone live yet?
Yeah, I'm going to go live now.
Do you know how to do it?
Yeah, I've
Just waiting to
started it,
check.
just making sure that Guru, is it on there?
Yeah, did you make it go live now?
Yes, I've made it go live.
Let me check. Let me check.
Go live now.
Yes, it is. All good. Carry on.
Okay, fine. Okay, good morning to all of you. Thank you for logging in and watching us today. We're going to have a CME on resuscitation. I think it's quite a historic day for us at GAS because I think this is the first time we are running two parallel classrooms. There's another webinar on remifentanil, which is going to start in a couple of hours. So I think we were approached by Irene, who has taken the arduous task of actually organizing a resuscitation course in Assam. And she said that there weren't many courses available there, and she approached GAS for having a sort of workshop webinar, and we were quite happy to oblige with that, and this is a result of that. And what was really unbelievable that all the faculty here actually said yes within an hour, and we could get this program done within a week. So I am really, really thankful to everyone. Thank you very much. I will ask Irene to say a few words. Irene, do you want to say a few words? Irene, you're muted if you're there. Well, I think Irene might be busy. So I think we have got a full day program packed for you. Oh yeah, I think Irene is there. Irene, are you there?
Yes, sir.
Do you want to say a
Hi,
few words?
everyone. Thank you so much for this organizing this webinar, and we have been so worried about like how to go and everything about this seminar, but you all make it so easy, sir. And thank you, Sip sir, for coordinating with every one of us, helping us in every step, and. I hope everyone who will be attending today will get what they want to from this resuscitation webinar. And this is specially made for all the participants who will be there in the critical care, what you call CPR workshop. So to all the students and faculties who would be attending, this is a great opportunity. Please interact with your faculties who are going to teach us today. Any doubts or anything that you want to ask them, you will have a question and answer time. So you can put your questions there. And all the faculties would be happy to explain it to you. Thank you, sir.
All right, thanks, Irene. And while we're giving the talk, if it's possible to just monitor the YouTube and see if there are any questions and ask us. Please ask questions, because I think one of the USP of our GAS meetings is that we keep most of our sessions interactive. We like to interact with the audience. We make sure that it's just not didactic teaching. People just don't come here, talk and go. But at the end, you've actually received some pearls, some tips, and you got some kind of take-home messages. Okay, without further ado, I think I'll start the first talk of the day. I am going to give the first talk of the day. And okay, so I hope I'm visible and audible. So if I'm not, please let me know in the comment section. So I'm going to talk about the principles of resuscitation. I think resuscitation is probably what we mean by resuscitation here is going to be more about instituting CPRs. And we'll be just talking about a little bit of what is a principle and why do we do what we do. I think this is probably one of the most gratifying, satisfying things you can ever do, when you can actually get someone's heart beating and when a patient actually wakes up after you have performed CPR. So I don't think so there's greater satisfaction than this. So what are we hoping to learn here today? One is to understand the underlying physiology, or what the basis of CPR is. The second thing which we want to do is we stress on the importance of a rapid response, okay? Problems which occurs with delayed resuscitation and effects of inappropriate resuscitation. I mean, this is going to be the whole pattern of talk today. So from understanding the principles of resuscitation to when we say not to resuscitate or organ donation, we've got a complete package where I hope the students will understand the process which we go through. So as with every talk, it's quite good to know history, right? Artificial respiration was actually first described by Sylvester in the 19th century, okay, and closed cardiac massage by Boehm in 1878. Again, Nielsen later on described artificial respiration in 1911. Peter Safar wrote the first ABC of resuscitation in 1957, following which there were quite a lot of papers which came in, one in 1960, and probably the most important paper is The Pulse of Life, 1962, by Jude, Knickerbocker, and Safar. And it was promoted to the public in 1970. Now, before I start resuscitation, one of the most important things is there are some stories which stick with you, and you will find that in your career, you know, if you're PGs to the time when you become advanced practitioners, there are some cases which really stick. And the reason I'm telling you the story of Mr. H is that this is one of the cases which has stuck with me for a very, very long time. I was in India at this time, and I was home. I was having my dinner, a very well-cooked dinner by my mom, actually, when I was suddenly called saying that someone had collapsed downstairs in my building. So there was a meeting going on and someone had collapsed there. I went down there and I actually performed CPR on Mr. H. And after performing it for around 15-20 minutes, that's when the ambulance came. The ambulance took him to the hospital. And in the hospital, they tried for another half an hour or so. And unfortunately, Mr. H passed away. So you might be thinking that, you know, I'm giving you a talk on resuscitation and I'm talking to you about someone I could not resuscitate. I learned a lot that day. I mean, I don't think so I had any doubt with the CPR which was performed, but I was doing it alone. I even had my anesthetic kit, so I had intubated him. And so there was someone bagging the patient and I was performing CPR. Then when the patient went to the hospital, it was very bizarre because when they showed me the bill, he was billed for 800 ampules of atropine, which was given, it seems. And he had a pacemaker for which he was billed. So they had put in a temporary pacing wire to resuscitate him. And the story then, you know, went on to for us to realize, when I went and looked at the websites and the Resus Council websites, you know, there's nothing mentioned about anything of that sort. And that made me realize how important it is that each and every person knows about resuscitation, and resuscitation is done in a very protocolized and a very individualized manner. So protocolized is very, very important. And I think we need to remember that. And the reason is that when you have a protocol for something, when you follow a certain format, one, it protects the weakest person in the links. Second, each person in the link knows what his responsibility is, and everyone knows what comes and what follows, so that people can be ready for the next action. For example, to give a DC shock or the next dose of adrenaline, or maybe giving amiodarone, things like that are very, very important. So when I used to be in India, and we were practicing intracardiac adrenaline at that time, it's something which is not practiced anymore. So that's the reason why I think each and every person should know what the normal steps in resuscitation is, basic life support and advanced life support, so that everyone sings from the hymn sheet, and anyone in the team is capable of correcting. And I think it is very, very important to acknowledge that. Now, if you look at UK data, yeah, out of hospital, and the other thing which I'm going to tell you is that there are people who are going to be talking today there are some people who follow the AHA guidelines. I am from the UK, so I follow the Resus UK website and I follow their guidelines. The India has its own guidelines, but it doesn't matter, right? As long as you are familiar with some guideline, that is the most important thing. Discuss with your, your department or your colleagues. Embrace one guidelines. I think India mostly goes via the AHA guidelines, so it is fine by that. Doesn't matter. Any guideline is good. There are plenty of websites. Resus Council UK is a very, very good website. We follow that. So hence, most of the data I would talk about is going to be from the UK. So 55 per 100,000 cases of cardiac arrest are there every, in the UK, half of which are witnessed. Of all the people who receive CPR, bystander CPR is instituted in 70% of the cases and ambulance CPR in 30% of the cases. So even before they come to the hospital, the CPR has been initiated. And that's the reason why there's so much emphasis on trying to do things like calls, get the public aware about resuscitation, and make sure that someone can start resuscitating. The initial shockable rhythm is present in around 1 in 4 of the cases. And even in a country like UK, where each and every place you go, there is an automated external defibrillator available, only 1 in 10 cases, the AED is used, which is very sad. I think there has been an increasing focus on us trying to use it more. ROSC is achievable in 30% of these cases, and the ROSC improves to around 50% in cardiac cases. And that's the reason in a country which has got so many pathologies which is directly linked to cardiac arrest, that having an AED in public places, recognizing how to do CPR is very, very important, because survivals following cardiac cases is much better than survival following a rhythm like an asystole or a PEA. Overall survival is 10% to discharge. So they might survive hospital admission, but discharge survival is slightly poorer. In-hospital cardiac arrest is like 1 to 1.5 per 100,000 hospital admissions. Most cardiac arrests occur on ward. ROSC is achievable in 50% of the patients who have got in-hospital cardiac arrest. And if you actually have a cardiac arrest in the hospital, then 23.6% of these patients survive. So that's not bad. 1 in roughly 4 patients will survive. And 83% of the patients have a favorable neurological outcome. And I think most of this is actually attributed now to the fantastic policies and protocols which we have in place, and everyone following these policies and protocols. These policies and protocols are evidence-based, and I am not going to hesitate to repeat this again and again. Please follow the Resus guidelines to the letter. It does work. Okay, so 19.3 patients having an in-hospital cardiac arrest have a favorable neurological outcome, but this does not take their pre-existing comorbidities into account. And I'm playing the devil's advocate here, is that if you actually have someone who's got an irreversible disease, which is never going to get better, you've resuscitated them and you've got that person to the same state, yeah? You can't reverse their comorbidities. And sometimes, in my last talk, I will talk to you when you're talking to the relatives, you have to take this into account. Is resuscitation in the best interest of the patient? And should you be doing that? But that's a completely different question. And that's a question we will hope to answer towards the end. Now, I got and looked at the papers because I'm giving a talk which has got largely an Indian participation here. In India, if you look at that, mortality is 4,280 per 100,000. That's very high, okay? Compared to, UK, we're talking about 55% of cardiac arrest. We're talking about, around 60 to 120 in the US. And this is like 4,280. And 60% of all these deaths are cardiac deaths, okay? And 70% of those cardiac deaths occur at home. 90% mortality for out-of-hospital cardiac arrest. And immediate help is available only in 46% of the out-of-hospital cardiac arrest. And, by actually doing things like bystander CPR, we can improve the outcome of outpatient out of hospital cardiac arrest, because we do see from time to time, there's a lot of patients who come into my intensive care who have had out of hospital cardiac arrest and they've had fantastic bystander CPRs. And these patients do well. There are patients who do well, but again, depends on what the pathology is and why the patient had the cardiac arrest in the first place. So myocardial infarction, coronary artery vascular deaths, 40% of deaths occur in age less than 75 years. Mean 28-day fatality is around 50% in 35 to 69-year-old. So 50% of these patients will die within 28 days. Most die in the first hour and before reaching the hospital. Present with VF or pulseless VT in case of cardiac arrest which occurs due to myocardial infarction. This is the rhythm which you will find, and it is a rhythm which is treatable. And what you need to treat them is early defibrillation, because delay in each minute decreases survival by around 7 to 10%, and greater than 12-minute survival rate is as low as 2 to 5%. You might as well, give up. But that's why early defibrillation, myocardial infarction is very, very important. I'm sure a lot of my speakers are going to stress this to you as the talk goes. And this is just data on, like, when you actually have witnessed in hospital cardiac arrest, your survival rate is around 22% and ROSC is achieved in 48% of the cases. But even in a hospital, if you actually have an unwitnessed cardiac arrest, your survival is just 1%. So a witnessed cardiac arrest has a higher chances of survival. That is because we do these kind of training, we do these kind of courses, and we know what to do in that situation. For bystander CPR, ROSC is achieved in 40%, but survival is only 4%. And the reason for this is probably inappropriate CPR, or the technique of giving CPR is not good. With no bystander, if they wait for ambulance, then ROSC is only achieved in 15%, out of which only 2% survive. A defibrillation within 3 to 5 minutes, look at that number. ROSC is in 74% of the patients, and 30% of these patients will survive. In the context of resuscitation and someone having a cardiac arrest, if 3 out of 10 patients survive, that is a very good number. So aims of doing CPR: 1 is to maintain your cardiac output. 2 is you have to maintain the oxygenation. Prevent brain damage. Now, this is a very important thing. And a lot of patients, you might be able to get the heart back. But if the brain is damaged irreversibly, I don't know, how people perceive that kind of existence. And of course, to prevent cell death. The main objective, remember, is to delay brain death and keep the heart responsive, right? So start your CPR quickly, keep your patient oxygenated, maintain the cardiac output. And in that, while you're doing that, you prevent brain damage occurring and you keep the heart going. Now, pathophysiology, this is the same thing which occurs with any kind of shock, or when your heart stops, you have cessation of your blood circulation. This causes a reduction of oxygen delivery to your organs. When that happens, your inflammatory system goes berserk. It starts releasing all kinds of catecholamines. It starts generating free radicals. It tries to redistribute the blood from your peripheral organs to your central organs. That's the reason for this intense vasoconstriction. So all blood and everything can come to the central pool, because it wants to protect your major organs like your brain, your kidneys, your heart, and of all the organs, probably kidney takes the biggest hit anyway. There is a redistribution of blood flow. Okay, the lack of oxygen causes anaerobic metabolism and acidosis. There's a relative vasodilatation of the cardiac and cerebral vessels. This occurs because of the local chemoreceptor response, which occurs with autoregulation. And once this starts happening, you start getting rhythm disturbances, and because of the acidosis, you get decreased sensitivity of your vasculature to catecholamines. Once you are severely acidotic, your blood vessels do not respond to the catecholamines like they would respond normally. Okay, the damage to the brain occurs in 4 minutes, okay, and irreversible damage in 7 minutes. Restoration of pre-arrest neurological function is rare in untreated cardiac arrest of greater than 10 minutes. And heart is the second susceptible organ here. So even with the best quality CPR, please remember that a period of global ischemia always occurs when your heart stops, right? So all you're trying to do is secondary damage control here, okay? You want to prevent any more damage occurring. Okay, theories of forward flow. It's very interesting when Sylvester described his chest pressure arm lift and Jorgensen described the back pressure arm lift. This was the original paper which I dug out from somewhere where they were talking about how to do CPR in those age, where you can actually say they are doing something where they're compressing on the heart or moving the hands away. This was more for your respiration more than anything else. Okay. So there are two theories. One is the cardiac compression theory, which was initially proposed by Cow and Hoven. And it's very simple. Your heart is in between your sternum and your vertebra. Direct compression of the heart between the sternum and the vertebra creates an artificial systole. Okay. They also postulated that the raised interventricular pressure, which is created when you actually give a cardiac compression, it closes both your tricuspid and your mitral wall, and it opens your aortic and pulmonary walls. And hence, it actually causes forward flow. Okay. And when you release your pressure, ventricular filling occurs when the interventricular pressure falls, forcing the bicuspid walls to open. Now, you are able to give around 30% of the normal output by this mechanism, and you should maintain a rate of around 100 per minute. Remember the oxygen content of venous blood. If you remember the formula for oxygen content, right? You will find that the arterial blood content is somewhere around 20 and the venous blood content is around 15. And what you require is just 5. So your venous blood still has a significant oxygen content for you to oxygenate. And that's the reason why more emphasis is being raised on actually compressions rather than respiration during a cardiac arrest. After 30 years since the original theory was described, John Hopkins, the academicians at John Hopkins actually came up with a mechanism which they call as the thoracic pump mechanism, in which they postulate that the blood flow results from changes in the intrathoracic pressure. And this occurs because of the collapse of the airway. And there's a pressure gradient which occurs between the intrathoracic vessels and the extrathoracic vessel, causing forward flow of the blood from the lungs into the systemic circulation. And after the compression ends, because the intrathoracic pressure falls, the negative pressure causes the blood to come back to the lungs. Okay. And their postulation is the heart just merely acts as a conduit. All right. So this compression does everything with the blood in the thorax and the lungs rather than the heart, and the heart is the conduit. So both this, there's never going to be agreement. The only thing which was debated was when John Hopkins initially told about the thoracic pump mechanism. They said that you should get the heart rate down to 60. So long ago, people used to do CPR at 60 because of the thoracic pump mechanism. Then there was a study which was done in animals where they actually did CPR at a rate of 60 and the CPR at a rate of 120. And they found that the animals who were given 120, the CPR at a rate of 120 did better. And they had much better ROSC, and that's the reason why we advocate a higher rate of compression now. The chain of survival, I don't get confused. There are a few slides you will see which have got the American chain of survival. This is the one which we have in UK, and it's basically the same. Early recognition and call for help, early CPR, early defib, and post-resuscitation care. As simple as that. Okay. Now, every year, 5 years, there's a guideline review, guideline changes which occur. I mean, over the years, there's few messages which has come, which is like interruptions in chest compression is common. So you avoid interruption in chest compression. You have to continue chest compressions. If you delay CPR, it's associated with reduced chances of survival. And compressions only CPR is effective for around 5 minutes. Afterwards, you have to get some kind of oxygenation. But again, it is better than not doing anything at all. Okay, so the system level factors which are being looked upon. So social media, where we are on social media at present, and I think we are a great fan of social media. Social media and smartphone apps are being done by various research councils to actually help people understand what to do during a resuscitation. Promotion of community initiatives like Restart a Heart is done in schools here, where kids are taught how to do the compression-only life support. Ambulance dispatcher, whenever they are there, they get the bystanders involved, show them how to do a CPR, and then of course, there is an impetus to have specialized cardiac arrest centers which will only look after cardiac arrest. Capnography is also coming to CPR, and I think if you have something in the hospital, and as anesthetists, we have access to capnography. Capnography should always be used to confirm a tracheal tube if it's spaced during CPR. It can also be used to monitor the quality of CPR. You can actually see when you're doing a CPR that there is some kind of CO2 coming up. And if your return of spontaneous circulation is established and your blood pressure is improving, your organ perfusion is improving, you see a very good quality of CO2. But as with everything, interpret the CO2 changes very, very carefully, okay? What I'm trying to say here is that people who are not experienced enough might interpret it in a very different way. So just because there's quite a good CO2 trace, do not just neglect the blood pressure. At the same time, because there is not a very good CO2 trace, but very good pulse, equally be very careful in interpreting those kinds of results. So defibrillation, I'm just not going to talk much about it, but what defibrillation basically is that when you actually give a shock, you've got a fibrillating heart. When you give a shock, the whole of the myocardium depolarizes and it stops. And it is the pacemaker which actually starts functioning first. And hence you actually convert an abnormal rhythm to a normal rhythm. And this is the basis of CPR. But success, of course, depends on various things like, you have to pass an adequate current, your pads have to be in the proper place, their contact has to be good, there are multiple factors there. So factors affecting success is transthoracic impedance, the shock energy, whether it's a monophasic or a biphasic defibrillator, and also the electrode position. And things actually which affect your transthoracic impedance are things like paddle size, paddle skin coupling, how well they are placed, the distance between the electrodes, the ventilatory phase when you are applying shock. So normally, I hope you disconnect oxygen and you stay away when you're having a shock, you're not ventilating. Paddle pressure which are applied to the patient, and number and interval of shocks. I'm not going to go through this. Biphasic defibrillation, it helps lower the threshold, lower shock energy is required, longer refractory periods, and requires smaller capacitors and batteries. These are the classical positions of applying your pads in the anterolateral position, where you actually have the right side just below the clavicle, and on the left side near the apex, or some people just put it near the axilla. If you're doing the anteroposterior position on the front, you put it just slightly lower, parasternally on the right side, and the back, you actually put it there, which is slightly lower than the one which is anteriorly. So the current passes, because your heart, if you actually look at it, is located this way, right? This is where your heart is located. And that's the reason for allowing the current to pass in that direction. Now, you can use either of these techniques. Most commonly, we'd use the front because the patient is readily available, but there's more and more evidence that having anterior-posterior may be better, but the debate still rages on. Okay, safety. One of the biggest contraindications of doing CPR is actually if you who are providing the CPR are not safe. Okay, so there are a few rules which you have to remember. You charge the defibrillator only on the patients or in the cradle. Okay, try to avoid contact. There are multiple case reports of people actually who have defibrillated each other. So don't do that, please. Okay, make sure you are not standing in puddles of water while you're shocking someone, and make sure there are no oxygens available. There's a thing about transdermal patches where they say that you should ideally remove your transdermal patches if there anything is present or anything is visible to you, but don't waste time trying to look for them before to start CPR. Okay, the AEDs, amazing things, available everywhere, but as I said, used only in 1 in 10% of the cases, which is very, very sad. It recognizes VF and pulseless VT for you. Sorry, that should be VT. It charges and shocks. Okay, it has its own mechanism. You can override it if you think that it's talking nonsense. Okay, there's no pulse check or anything available, so you actually have to do a pulse check in between, but it'll tell you to do the pulse check. Okay, and the only problem with it is sometimes it does not detect fine VF, but in which case, if you are already performing CPR, that's fine. The most important thing is to perform CPR. So I'm just going to quickly cover a couple of pharmacotherapy. Okay, the commonest drugs which are used are adrenal vasopressin, amiodarone, magnesium, atropine, bicarbonate, lidocaine. Adrenaline is given 1 milligram every 3 to 5 minutes. There's no evidence by giving a bigger dose you achieve anything, but a smaller dose also doesn't achieve anything. So we've stuck with 1 milligram every 3 to 5 minutes every cycle, depending on what the pulse is. But you will find that irrespective of what the rhythm is, when it comes, when you have to do CPR, you will be giving an adrenaline ampule every 3 to 5 minutes. It improves coronary and cerebral perfusion. It acts on adrenal receptors. It may cause arrhythmia, but in this case, you're not worried about it. Arrhythmia is better than sometimes just putting the patient from asystole to a VT, and VF helps you achieve, defibrillate the patient and get a rhythm back. As I said, no advantages in high doses. And can I just say that a lot of people try to do these intracardiac injections. There's no longer a role for that. At least we don't do that in the UK. So vasopressin is there on some of the ACLS protocols. Instead of using adrenaline, they use vasopressin. That's because it stimulates V1 receptors. It's a very effective vasoconstrictor, and a dose of 40 units is used for that. Amiodarone is, all of us know, is a class 3 antiarrhythmic and increases the AV node refractiveness. That's why it actually helps revert arrhythmias. It's a chemical cardioverter. So in CPR, we usually give it after you've given the third shock. Okay. Remember, it's a myocardial depressant and can also cause vasodilatation. So it can drop blood pressure. And a further dose of 150 milligrams is administered if you have given 5 shocks already to the patient. Lidocaine is given only if amiodarone is unavailable. Yeah, it is a sodium channel blockers. It slows conduction, and it's a membrane stabilizer. At 100 milligram IV, what is given for a VT. Yeah, I mean, some people recommend 1 milligram per kg or 1.5 milligram per kg too. I have not used it in a very, very long time. But yeah, you don't have amiodarone, you could use that. Sodium bicarbonate, you should consider in hyperkalemia and tricyclic overdose. Personally, to inject is frightening. It should not be used. Only if your patient is severely hyperkalemic, or you think the patient's had a tricyclic overdose and that's the reason why he's had a cardiac arrest, maybe it might be useful. It actually is a negatively ionotropic agent. It worsens intracellular acidosis. It causes hyperosmolality due to an increased sodium load, and it causes the leftward shift of your oxygen dissociation curve. So I'll be very careful. Conclusions: early CPR and good post-resuscitation care is the order of the day. VT, VF are more common, okay, and that's why early detection and early defibrillation is very, very useful. And being an intensivist, I would always say that consider CPR status in advance for critically ill patients, because it might sometimes not be in their best interest. And one of the reasons why in-hospital CPRs are reducing is we've gotten better in actually detecting them. With that, I finished my talk. Thank you very much. If there are any questions, we can go ahead with that. Does anyone have any questions? Or has anyone seen if there are any questions in Facebook? No? Does any faculty have any questions? No questions? Okay. Shiv, any questions?
I actually listened to only partly because
Okay.
I was getting ready.
That's fine.
Yeah.
Okay, I think generally,
Yeah.
I think what we have discussed are principles. Maybe as we go along, we'll get more questions. So I think we'll move on to the next talk. So the next talk is going to be given by Megha Gupta. I welcome her and I leave her to introduce herself. I think she's going to be talking about basic life support. So Megha, if you're ready, you can start sharing your screen and you can start your talk, please.
Hi, good afternoon. Dheeraj, could you please enable the screen sharing again? Okay.
I'm being too greedy and selfish, just keeping it to myself.
In the meanwhile, Hi, good afternoon, everyone. I'm Dr. Megha Gupta. I am a specialist anesthesia practicing here in the UAE since past 8 years. Prior to that, I was working in India. And here we follow the AHA guidelines. But as Dheeraj has rightfully said, they are mostly the same. So without further delay, let me start sharing my screen here. And okay. So today I'll be talking about BLS or BCLS, Basic Cardiac Life Support or Basic Life Support. The latest terminology is Basic Life Support, the latest one, because cardiac is a part of it. But as you have heard in the talks before, brain and other vital organs perfusion is also important. So what are the components of a basic cardiac life support? Let me start by saying a few things. As the name suggests, it is basic cardiac life support. So mainly we will be talking about the out of hospital cardiac arrest scenarios, and of course the inside hospital as well, because it always starts with basic cardiac life support, goes on to advanced, but you do not wait inside the hospital. But outside the hospital, what happens is maybe you are the sole responder, or as I have been given idea by Irene that some of the people who are attending this course are not anesthetists, some of them are in other faculties. And as I said, as all of us know, cardiac arrest can occur anywhere. You may be traveling on an airport. We have stories. I mean, people have saved somebody on an airplane or in a bus stop or a mall or your clinic. You may be in your dental clinic and a patient can have an event or whatever. So basic cardiac life support or basic life support is you can give anywhere. And these are the steps you should remember. And I'll be repeating quite a few of them, as also in your class, you will be repeating a few of them because compressions is the key. And if earlier you start the compressions, the better is the outcome for the patient. So main components of any basic cardiac life support training or BLS training would be, first, you will learn about the high quality CPR. What are the components of high quality CPR? Then you will learn the use of AED. What is AED? It is automated external defibrillator. While traveling, you could have seen it, especially at the airports or bus stops or in the malls, you will see that there is a station, there is a lock and key. Inside it, there is a AED placed. So the security of the mall or the airport are aware of where this AED is placed. So you should know that AED is available. It is mandatory in most of the places and it can save somebody's life. And last but not the least, the choking response. It is part of basic BLS training. So all of us should know how to take care of choking adults or children. So you in a BLS, these are the components and it can buy you time till your advanced support comes in place and maybe you can save somebody's life. So you need not be a doctor, you need not be a physician, you need not be, even a bystander can give most of these basic life support steps. So we are going to revise them again and again. Sorry if I get repetitive, but it is repetitive. And as Dheeraj said, protocols is everything. So if you follow the steps of BLS, you will definitely save somebody's life. So steps are important and do not forget each and every component of it. So for that, whom to give the BLS? So you have to be able to assess a responsive patient from an unresponsive one. So what is responsive and unresponsive? So let me make the mood light. There was this very 90-year-old gentleman admitted for some fracture femur in the ward, and he was edentulous. And if you have seen your grandparents or somebody, he was sleeping in the ward very peacefully, but his mouth was open and he had very shallow breathing. It looked dangerous. So a few residents were passing by, thought that maybe this old gentleman had a embolism or something, and they started the CPR and he woke up. So first assess whether the patient needs BLS or does not need BLS and then start with it. So how will you check for responsiveness? And again, I would like to say BLS given is better than not given. So even if it was a wrong BLS, it is still okay. But if it was needed and you did not give it, it is wrong. So what is a responsive and what is an unresponsive person? So a responsive person is a person who will move or speak or blink or otherwise react when you tap on the shoulders and ask, are you okay? So are you okay is a general term which we are using. whichever state, whichever place you are in, please use the local language. The person may not understand the words, are you okay? So the thing is, tap on the shoulders and see whether there is any response. Aap theek ho, are you okay? Whichever is the prevalent thing over there. And what is an unresponsive person? A person who does not move or speak or otherwise react. So in your basic life support training in the BLS course over the period of 2 days, the first half, you will learn how to assess the responsiveness of a person. Okay, so that is very important part. And something else that you need to understand is something called as ergonal gasps. What are ergonal gasps? So a person in cardiac arrest will not breathe normally. There will be air hunger. It may sound like a snort or snore. There will be labored breathing. There will be abnormal movements of the neck. But don't confuse it with breathing. So it is not normal or regular breathing. And it is a sign of cardiac arrest in some of the unresponsive patients. So please learn to differentiate between ergonal gasps and some choking or the normal breathing. So you will be shown videos of this and how to differentiate between ergonal gasps and normal breathing. Then, as I said, this can happen anywhere in any place. So assess for the scene safety. So even before you see, if you start BLS or anything, see that the scene is safe. Now, what do you mean by scene is safe? It should not happen that you start giving BLS to the patient and then you yourself get electrocuted or something. So assess the surrounding, have a quick glance. Are there any fumes? Is there any fire? Has the person suffocated? Or is there any water or any live wires? We are in India. So there is possibility that this person might have got a shock due to some. So see that while you are going to help, you should not fall yourself in danger. If you are not safe, you will not be able to save others. Okay. So assess the danger. Then if there is any help around, what is meaning by help around? So you see the person is lying flat on the ground. And in a danger, I mean, the patient could have an arrest on busy street and there is a huge traffic. You could be hit by some vehicle when you are trying to save. So assess the danger, then see if anybody is around to help. So if you start with the CPR, ask somebody else to call for help. Maybe your local number or emergency number, whichever is prevalent to that place. Then if it happens inside the hospital, usually most hospitals have an emergency number or a code number which to dial and announce and call for help. But if you are in a small clinic or something, maybe you're in your dental clinic, ask your assistant or the reception outside to call for help. The nearest hospital or nearest ambulance or nearest doctor or whichever facility. So in case of emergency, the number is written. Even in the bus stops at airports, in case of emergency, call the number. So when you start the CPR, ask somebody to call for help. Don't waste a time. Or if you are alone, just put your mobile on the speaker. Everybody has mobile these days, and then ask somebody to call for help. The next question is who and how many. Maybe it is a fire or choking or something and people are running out. So how many people are injured? How many of them require the help? Or it is just one person? So it is outside hospital scenarios, assess the scene safety, how many people are there. And last but not the least, where is very important. You cannot just say, I need help and I need people. Where are you? Identify your location. Otherwise, the help is going to waste time going around the facility and you will not get help at a proper time. Okay. So identify your place. Say you are on the second floor, room number 13 or wherever you are. So identify your place. The next important thing is taking of universal precautions. If it is an unknown patient and you have the facility to wear gloves or goggles, if the person is bleeding, see whatever you have and take care of yourself first. You don't have to dive head in and get injured yourself. But as I said again, if it is a family member, God forbid, who needs your BLS, you will straight away go and start it. So according to the situation and assessment of safety, use your common sense and the available things where you can take the universal precautions, take your safety also first in consideration. Okay, now we begin with the actual BLS, how it process. So you have ensured that the scene is safe and then you tap on the victim's shoulder and ask, are you okay? Maybe he says, yeah, okay, I'm fainting or whatever, then no need to proceed, just observe maybe turn on one side so that the airway is not obstructed, rule out that there is any cervical spine injury and such stuff, and then call for help because this person has fallen down, and but that means he or she is not well and needs your help. So look at what is the responsiveness and decide your further course of action. Upon asking, the person says, does not respond. That means the person is not responding, no noise, no nothing. So what you will do is look, listen, and feel. So your ear goes near the patient's head end, and your eyes are looking at the chest for any visible rise in the chest, any breathing. Even if he is breathing in and or out, you can feel the blast of air. Other way, while looking at this, is checking for pulse. In adults, we do it at the carotid. It is just lateral to your trachea. You can put the fingers here and see if there is any pulse you can feel. And in pediatric patients, you will check for the brachial pulse. Okay. Then look, listen, and feel, but do not spend more than 10 seconds waiting for some miraculous breath to occur, because time here is brain. So as a very important point is assess for the chest movements, but do not spend more than 10 seconds over it. If there is no, now after checking for the response and assessing that is the person okay, no response, you look, listen, feel, there is no evident chest rise, no nothing. That means the person is not well. He needs your basic life support to be started immediately. So how do you go about it? So we will discuss the adult chain of survival in response. First thing is you have to identify, and then so first is you recognize it, and emergency call number you have to send for help, and then immediately start performing high quality CPR. So this high quality CPR, there is emphasis on chest compressions. Then maybe with the help we'll get you an AED. And then if there are more people with airway or something is there, ambulance arrives and you shift the patient to a cardiac center or nearby hospital who is able to take care of the patient. So that is how it is going to proceed. So just a quick adult chain. This is AHA, adult chain of survival. First, you have to activate the emergency, then start the high quality CPR, defibrillation as early as possible, as you can see here. So defibrillation as early as possible, then shifting to a higher center and post cardiac arrest care. So this is how usually adult chain of survival proceeds. Now, what are the components of high quality CPR? You have assessed the patient. Are you okay? The patient is not okay. The scene is safe. You're not on some busy street, but the patient has just collapsed on a pavement. So ensure that the patient is on a flat surface. If you go to some hotel and you are called at any doctor and the patient is unresponsive, something like that, he may be on the soft bed and the chest compressions are not going to be effective. So you may have to place some pad below the back so that the chest compressions are effective. So sometimes you have to be innovative, but first ensure that the scene is safe. Then ensure that the person is on flat surface. Now in your BLS training, you will be taught how and where to give the chest compressions. So usually it is on the lower part of the breastbone for a layman, or in the lower third of the sternum if you are a medical person. So the exact position you will be told where to give the chest compressions and how to give the chest compressions using your two hands. The elbows should be straight. I will show the diagrams later on. So push straight down at least 5 centimeters or 2 inches. So that will give adequate compression to the heart between the vertebral column, as Dheeraj has rightly pointed out, the vertebral column at the back and the breastbone up. So this will compress the heart and effectively it will give in the cardiac output. So circulation will start. So this is the principle of compression only life support, which we call as COLS. So rate of it should be at least 100 to 120 per minute and count out loud. So 1 and 2 and 3 and 4 and 5. 6, 7. So count. It should not be like 1, 2, 3, 4, 5, 6. There has to be a adequate time given for chest recoil after the compression. So what happens is when you give adequate relaxation in between the compressions, there is return of blood flow to the heart so that heart is filled. Otherwise, if you do not give time for the chest compressions in between the chest compressions to recoil, the heart will be empty. So pumping the empty heart is not going to be of any help. So these are the principles of high quality chest compression. And last but not the least, try not to interrupt the chest compressions for more than 10 seconds. So even when you are giving the breaths in between, you have second person helping you out in your basic life support. try not to interfere or stop the chest compressions for more than 10 seconds. Okay. So these are the very important components of high quality CPR. I will revise them once again. Push hard, push fast, push at least for 5 centimeters or 2 inches in an adult. This is, we are talking about adult. Push at least at the rate of 100 to 120 per minute. Allow adequate chest recoil after chest compressions and try minimum interruptions of less than 10 seconds. Another thing is usually added is when you are ventilating, see that you are not inflating the stomach and each breath is given over a period of 1 second. While you are giving the breath, watch for the chest rise. Okay. But I have not included this in this side because this could be a layman doing a CPR who is not very well versed with the ambu bag and mask. So once you are using it in your training, you will learn all these techniques, how to hold the mask, how to give the breaths and all. But as again, do not interrupt your chest compressions if you're a single person for more than 10 seconds. So how do we go about it? So in this, you can see the position of the hands. The elbow should be straight. The pressure should come from the shoulder straight down to the chest, the back. And because believe me, if you are giving chest compressions for 2 minutes, like 5 cycles, you will be exhausted if you give proper chest compression. So do not tire yourself out. It is a very, very tiring scenario. So in basic life support station, when you are having the hands-on training, learn the correct techniques of giving the chest compressions. Now here I am showing this is the position where you are on the side of the patient. Then you, after 30 compressions, you will be giving 2 breaths using this pocket device. Now let us go to how to give the breaths. Okay. And this is your position when the 2 of you are giving chest compressions. Suppose you are lucky and you have somebody who has done a BLS course along with you. So one of you can ventilate and one of you can give the chest compressions. After every 2 minutes, you are supposed to switch the roles so that one of you doesn't get tired. If you are tired, the chest compressions are not going to be effective, and if the BLS is not going to be effective as it should be. So anytime during your BLS, if you feel tired, say that I am tired and give the handover after your 30 sets to somebody else to start the chest compressions. Okay, but as I said, compression should be effective at effective rate, effective depth. There should be adequate recoil, and that is the reason you keep on turning, change the compressors. So more people in your unit or in your area of work, the more people trained in BLS, the better the chances of outcome. Okay. And another reason that even the security, the ambulance drivers and the mall personnel working are encouraged to have first aid courses so that you have more hands to help yourself and you are not tired and the chances of saving somebody increase. So this is the importance of basic life support. Here you can see how when there are 2 rescuers, how 2 people can give even to this small infant here. Okay. The next important thing is opening the airway. So for all victims, unless you are suspecting a cervical spine injury, you can extend the neck and push the head forward. What happens is the tongue falls down and it opens the airway. So in this diagram, you can see what is a blocked airway and how the change in position opens the airway. But if any doubt regarding the cervical spine injury, or he is hit by a vehicle or hit in the pool or anywhere, just don't play with the cervical spine. You will cause more harm, but continue with the chest compressions. They are mandatory. Okay. Again, in your BLS stations, you will learn the correct use of oropharyngeal airway. These airways are part of adjunct of your crash cart, or they are in your first aid kit. How to put the oropharyngeal airway is it will keep the tongue away and the airway open. So you can ventilate the patient better. And the second component, the compressions, then airway. So airway and oxygenation is maintained. Without oxygenation, the brain is not going to be very happy about it. In the BLS course, you will also learn to measure the correct airway size, which will be asked in your questions in the MCQs, which is a part of your theory exam. So how to measure the correct airway size? It is from angle of the mouth to the angle of mandible, the nasopharyngeal airway, when to use, when not to use, how to insert. Because a smaller one will also cause obstruction, or a larger airway will also cause obstruction. So it has to be the correct size of the airway. So you will learn to determine how to use the correct size airway. Okay, this is a part of your BLS. Now, some other considerations. It is not that only a elderly person is going to have a scenario where he or she will require BLS. Anybody can require BLS anytime. So special considerations is for compressions in a pregnant lady. So usually what happens in a pregnant lady is the uterus itself compresses the inferior vena cava and great vessels of the abdomen. So whatever you do with the chest compressions, there is going to be difficulty in venous return. So resuscitation efforts are wasted if you do not give a tilt. So try to displace the uterus away from the great vessels of the abdomen by placing a tilt or a wedge or a pillow or something below the right hip so that the uterus is slightly tilted. If somebody is manually available to pull the uterus away, do that and then continue with the chest compressions. Always remember your chances of BLS or ACLS being effective in pregnant women increase once you give this tilt. Then breaths without pocket mask. As I have advocated, take universal precautions. If you don't know the person, no need. If you are up to it, give the mouth-to-mouth breathing. It is up to you, but it is not advised in this era where the infections are very high. But God forbid, as I said, it may happen in your near and dear ones where the ventilation devices may or may not be available with you at all times. So in your BLS station, you will learn how to give breaths with a pocket mask device and breaths without a pocket mask device. So if you do not have a pocket mask handy with you, what you have to do is you have to observe, pinch the nose with your thumb and index finger. This part will rest on the forehead. You will slightly extend the head, take a deep breath and exhale by over the patient's open mouth. So the exhaled air contains some oxygen, around 16 to 17% oxygen, which will be sufficient. So ensure that the nose is closed, the mouth is open and you breathe out. As you are giving the breath, your eyes should be on the chest and you should see there is adequate chest rise with each breath. The air that you are giving should not go into the patient's stomach, but there should be a chest rise. If you do not see a chest rise or you have difficulty, don't waste time ventilating for more than 10 seconds. Immediately resume high quality CPR. So CPR chest compressions are very important, as I said. Then the pocket mask, which you may receive during your training, it's a triangular structure with a filter one way attached. So you should learn how to place the triangular part of the apex at the nose and rest of the mask covering the mouth and how to give the breaths using it. As I said again, try not to interrupt chest compressions for more than 10 seconds. If you are able to give the breath, there should be a visible rise in the chest. Give breath over 1 second, allow time for expiration, then give the second breath and immediately resume your chest compressions. This is how you are going to give your breaths. So you have started this chest compressions, you are good, you are not tired, and in the meanwhile, somebody you have sent for the help. Now, what is AED? Automated external defibrillator. It is found by the studies that most of the out of hospital or most of these scenarios where the patient has cardiac arrest has something called as a ventricular fibrillation or things like that, which can be revived by using AED. So early AED is emphasized upon in use of in your BLS algorithm. So remember that as soon as AED is available, use it. Maybe the person has collapsed in a mall and AED comes from first floor or somewhere, the security comes running with it. So as soon as it is available, you should be able to use it. You will be trained on one particular sort of AED in your training scenario. But most of AEDs are very straightforward with diagrammatic representation. So first thing while using the AED is to turn it on usually, and then it has verbal prompts. Try listening to them. What to do? Okay, so push up, put the button on, place the pads. So everything is prompted. It is just you have to listen and follow the orders. Plus the pads of AED has diagrams on it. If you don't know where to place the pads, it will tell you where to place the pads. Something at the chest and something at the apex. So you peel the sticker, place them on the patient's bare chest. So one is at the sternum, one is at the apex. So exactly as in the diagram, try doing that. Now, some considerations are you have to follow the prompts. If use adult pads for anyone who is above 8 years of old, 8 years or older. If you do not have pediatric pads for somebody who is smaller, use the adult pads anyway. So use whatever pads. Using AED is better than using no AED at all. Okay. So you have the AED, but you did not use because it was a smaller child, 7-year-old. No, you use it. Ensure that the pads are not touching each other. They should be farther away, or you can post them anterior and posterior. Again, all where to place the pads will be taught to you. Okay. So peel away the backing of the pads, follow the pictures. Then when the AED is analyzing, clear, and nobody should be touching the patient, not even for the CPR, because it can interfere with the analysis results. So after analyzing, the AED verbalizes advised shock or not advised shock. If it says advised shock, charge, and again verbalize clear, ensure that nobody is touching the patient, press for the shock button, there is a symbol on it, shock it, and immediately resume with your high quality CPR. Don't wait. But while, because you have already wasted time in analyzing whether the shock was needed for this patient, once it says shock advised, you charge it and you shock, so immediately resume high quality CPR. So even with this shock, if this myocardium has turned and again started the pacemaker activity, it is still weak. It can use the help of your chest compressions. So after delivery of the shock, continue with your chest compressions. So this is again one of the important point of BLS, to resume high quality CPR after the shock is delivered. So what is high quality CPR? Again, we will revise once again. Ensure that the rate and depth is maintained. So at least 5 centimeters or 2 inches, rate of 100 to 120 per minute. Allow adequate chest recoil after the compressions. Minimum interruptions, that is less than 10 seconds interruptions, even if you are giving the breaths, and each breath is to be given over 1 second period. Allow for check for the chest rise, allow for the expiration, deliver the second breath, and again resume high quality CPR. So these are components of your high quality CPR. They should never ever be forgotten. You should remember these in these particular order and have to be followed. As I said, these protocols are going to save somebody's life. You cannot make your own. These are protocols divided by the AHA or the Research Council. So you have to follow them. There is no, I don't want to, I want to wait, I want to give more breaths. No, it doesn't work that way. Follow the protocol. Interruptions have to be minimal. Okay. Okay. So this is some diagrammatic representation. As you can see here, the placement of the pads. So these pads, they have shown in different types of AED. So this is the on and off button. This is the on and off button. Once you put it on, it will prompt you, and each will. So this is the button where you shock. So shock delivered, when you are pressing, before pressing this button or this button, see that nobody is touching the patient. Otherwise, accidentally, you, the CPR giver, may be shocked. So I have received one. So it is very shocking, shock. So be careful when somebody is delivering the shock. Some special considerations. Remove the clothing of the patient if he or she is clothed. If it is a hairy chest, if you have some blades just in your first aid kit or something, remove the hair if there is time, but don't waste time. Or some people advise put one chest, do the waxing of the chest and then place another pads. Sometimes you may not have the luxury of having too many pads. Then shaving is a better option. The problem is hairy chest will increase the impedance and the shock may not be delivered properly. Okay, so hairy chest is not advocated. The other thing is water on or near the person. If person is totally inside the pool, of course, you will not be able to give CPR. A little pool, little water in the puddle is still okay. See if you can dry the chest where you are applying the pads, and that should be fine. But if the person cannot be submerged in the water, then it is not going to be effective. The person may have some implanted pacemaker somewhere, so do not put the AED pads over the pacemaker. It's not going to be effective. So place it slightly away, anterior posterior direction. You may have to use your common sense depending on the situation. Then any medicinal patch, if it is directly under your pad placement, remove it and you can give it or change the position of the pads. But you have to remove and wipe the medication first. Otherwise, it's not going to be effective. Any jewelry which is in the area, remove it or just take it away. But some minor jewelry is not going to change the shock. So let it be. Don't waste time on things which are not important. Just look at the basics. These are the things you should keep in mind. Okay. So now some important definitions in basic life support. So infant is somebody who is less than 1 year. Child is 1 year to up to puberty. Some courses, no, most of courses will tell you what are the signs of puberty, like appearance of axillary or hair in the private part. There is sudden growth spurt. So adolescent child, you will be able to distinguish. And after puberty or some cases 15 or 16 years, it is considered to be an adult. Now, this is how you check response in an adult or in a small child, maybe a 7 or 8 or 10-year-old child. And this is how you check response in a small child by tapping on the foot of the child. Then how to extend the neck of the child is shown here. A smaller adult or adolescent child, it looks more or less similar to what you do in an adult. So this is how you will check the response. Again, ensure that the scene is safe and ensure that the scene is safe. Actually, the person is unresponsive, and then go ahead, call for help. And when you're calling for help, start with the high quality CPR. Okay. This is a pediatric chain of survival. It is very important. The first thing in out of hospital cardiac arrest, even inside the hospital, prevention is the key, because kids are your responsibility. You have to prevent things from happening. So if you can prevent it, then you don't have to give CPR. But if you see it, then activate emergency, and as again, it is self-explanatory slide, high quality CPR. So prevention, and even inside the hospital, maybe the child is admitted under your care for some other things like loose motions or history of pneumonia or whatever. Early detection and prevention is the key, as again, do not let the child deteriorate under your care to such an extent that the child will require a CPR. Okay. And you have to look after the children, because they are prone for accidents. They will crawl and they will swallow things which are lying on the floor. So prevention is the key inside the hospital as well as the hospital. That is where it differs from the adult chain of survival, but the rest of the things are almost similar.
Megha, sorry to interrupt you. You might need to speed up a little bit, yeah? Because
I'll go on fast. Then the next one is the one hand technique and 2-finger techniques. Again, you will be learning them in the BLS. And I have again said use of child pads in pediatrics if they are less than 8 years. And if you do not have kids pad available, use whatever is available with you. Some significant differences between one person and 2-person rescuer is, even whenever you are a single rescuer, the ratio is 30:2, 5 cycles. Then get a AED, or if it is a small child, you can take the child with you, along with you. So there is no time wasted. The compression depth is 4 centimeter or 1.5 inches. And when the second rescuer arrives, the ratio changes from 15:2. So one of your important question is this ratio, and all this will be asked when the second rescuer arrives on the scene. You remember, important thing is to change the ratio to 15:2, because kids are more susceptible to oxygen and desaturation. Now, choking is a common thing you can encounter. So universal signs of choking, you may be at a restaurant, you see somebody choking. You should know something about Helmholtz maneuver. This is choking in a child, and how do you give those thrusts? This is the maneuver. What happens is you make a thumb and make a fist and a hand and give pressure directly below the rib cage so that the diaphragm is pushed. And by this maneuver, the foreign body may actually come out. This is how you do in an infant. So it is called as 5 downward thrusts followed by 5 back slaps. In your BLS training, you will learn these also, how to give that. Then in obese patients or pregnant patients, if you cannot go below the chest, you can give it the same maneuver on the chest. So it will help in dislodging the foreign body. Irrespective of whom you are giving the foreign body treatment, at any point during the resuscitation attempts in choking, person becomes unresponsive, straight away go to the basic life support and start with the chest compressions. During rescue breaths, if you see the dislodged object expelled, remove it if it can be removed easily. Do not swipe your fingers blindly in the child's mouth or in the adult's mouth. It may dislodge further. Call for help. And in pregnant women, do not forget about the wedge under the right hip. So I hope you will remember these revised points, and thank you for your patient hearing. Thank you so much. Any questions? I will. Thank you. Yeah. Hello.
Megha, excellent presentation. Thank you so much. I mean, I think you've covered amazingly most of the stuff which is there. There are a couple of questions, I think, partly probably to me as well as you. Let's see. Okay, so role of precordial thumb. Is there any
Okay.
role for precordial thumb?
As per the guidelines, if you do not have, and there is nothing, there is no harm in giving a precordial thumb. Okay. But it has no role per se. It may help, but it is not scientifically proved to be of any help. But rather the compressions are going to help you.
I agree. I think it's been a long time since I've thumbed someone. I mean, but most of the time we are in a hospital setting. So you're saying that if there's nothing, if you think it's a arrhythmia or something, which you really won't know just by feeling the pulse, because by definition, a cardiac arrest is one where you don't have a pulse. Otherwise, you will have a pulse. So there's no way you know that patient requires a defibrillation at that point. So an AED is probably the more useful thing. If search for an AED, you look if there's an AED rather than trying to go for a precordial thumb. But as you said, no harm. Role of atropine. I think this we'll probably cover later. I don't think so in this BLS there's any role for atropine at present. I think there's a lecture where this will be covered. And then, when is vasopressin indicated in the CPR protocol? So the reason I had vasopressin is that initially the American Heart Association or many American institutes use vasopressin as compared to adrenaline for their CPR, or their ACLS guidelines initially used to have vasopressin. I'm not aware of whether they still have it in their guidelines. So if you have adrenaline, and in India, I'm not sure whether you're going to find vasopressin so easily. You probably stick to adrenaline, and that is the reason why vasopressin is there. Again, yeah, it's very interesting what you mentioned, Megha, right? Because you have this thing about, you talked about being in a hotel or being in a flight. I mean, one of my recent flight, I had an adventure which was very, very strange, but I don't want to mention it in this open forum. But how are people protected if they actually try CPR in the air? So what is your view on that? If someone collapses in the air and you want to start CPR, should they do CPR, or should they say, oh, I'm scared about getting litigated, so I should not do CPR?
In India, yes, you should go ahead. I will say that. Yeah. In air, of course, you are protected. If you feel up to it and you feel you can save somebody's life, no harm. And yes, you are protected. If you have the proper license, you are licensed to give the CPR, but not here in the UAE. You're not. You usually do not.
Oh, is it? So I think the Good Samaritan law actually protects you from most of the problems. And the thing which you got to remember in air, when you are in air, you're not in any country. Yeah, you're countryless. You're flying in the air. So it's only when you land at certain places, and if you land in a place which you think is a problematic area, that is the only thing. But I think the Good Samaritan law, if you say that you've done it, and if you say that you have done a course like this, you know resuscitation, you've done your ALS or BLS, I think you should be okay with that. Any other faculty have any question here at this point? Oh, Shiv, please go ahead.
People just asked about thumb, precordial thumb. What about percussion pacing?
For me, no, I have no idea. No, I would not use it. I have not done it at any BLS course or nothing.
I think you're asking, would they use percussion pacing if they realize it? But you got to realize that the patient is a block for you to do something, right?
Absolutely. So I think I think it's 2021. There was a systematic review. Obviously, if you have this is a monitored patient and develop arrhythmias, you can use percussion pacing till you actually get the defibrillator.
Okay, that's a good point.
Yeah, but that also means that you shouldn't actually stop, for CPR and then do that. But if patient has been monitored, they have been oxygenated, they are actually getting good saturation, you can actually try it, but it is not part. So similarly with thumb has actually got no value. That's what they say. The other was like the cough CPR. Again, cough CPR, if somebody develops arrhythmias, awake patient monitored, you can actually ask them to cough and create a kind of Valsalva kind of maneuver, and then that is allowed. So these are just, they're not usual parts of CPR, but this is something which are usually asked.
That's a very good point. But ultimately, as you see with BLS, these
need
are
to-
things which are very, in BLS, I think you just do CPR. That's it.
Absolutely.
Because
absolutely.
unless
I
you
think
put a pad, once you have a cardiac monitoring, that means you are in an area where you can do something about it.
absolutely.
BLS is more in the community, and it becomes very difficult in that scenario to actually do that.
That's why a compression alone can be equally
Exactly.
Useful, even if you do not do the breaths. If you just do compressions, they can actually save a life.
Yeah, and it's very important that as a BLS, understanding. So BLS is absolutely essential when you are there in the community. Even as doctors, sometimes when we are there in the community, we might not have a Winflon, we might not have adrenaline, we don't have all these things on us. Unless you have your bag, which you take around everywhere, which is not possible. In which case, BLS saves life. This is what you need to know. This is the most important thing you need to do if you don't find anything else. Okay, so in the interest of time, Megha, the one last point, which I think you actually touched upon, is making the patient sure that the patient is responsive or not. It can go to the other end too, because many times if I get a 5 o'clock or a 6 o'clock cardiac arrest call in my hospital, it's usually found dead kind of patients. You see, I've had people actually do CPR, and when I've gone to a patient and you couldn't open the mouth, my registrar said, "This patient's actually very stiff. His mouth is not opening," and I said, "That's rigor mortis. So don't try to intubate and get the heart going in those patients," because it is very important to realize that you do CPR on people who are appropriate. But as you said, if you're not sure, even if low blood pressure, like in pediatrics, they say, right, if the heart rate is less than 60, commence CPR anyway. So I think that is the most important thing, and you rightly pointed that out. So if there are no questions, I am going to move on to the next speaker. So the next speaker is Dr. Prasanna Kini. Would you want to introduce yourself, Prasanna, and then start your talk? Thank you very much.
Thank you, Dheeraj sir. And firstly, I would like to thank the organizers as well for giving me this opportunity to speak on something that is so very important in today's world. I mean, doing BLS, knowing BLS, and actually being a good provider can go a long way in saving lives. And that's what we are here for as medical professionals, right? So am I audible?
Yes, you are. We can see your slides and you're audible. Thank you.
Okay, thank you. So today we had a lovely talk by Dr. Megha on BLS. And so I will be taking it to the next step with advanced cardiac life support, which is also called advanced life support or even comprehensive cardiac life support, because now what is seen is that there is not a proper delineation between where BLS ends and ACLS starts. So every ACLS protocol starts with BLS first and then is taken over to the advanced level. So what is advanced cardiac life support? It refers to clinical intervention for urgent treatment of cardiac arrest and other life-threatening medical emergencies, as well as the knowledge and skills to deploy those interventions. Now, as people working in the healthcare sector, most of us will encounter the patient at a level where the patient might already have got the basic life support from bystanders or probably in the hospital from people who were around there. And the patient is then transferred under your care for the advanced support. So there are many different guidelines, as Dr. Dheeraj had mentioned. But in India, we usually follow the American Heart Association protocols. And this is reviewed every 5 years with evidence. The last review was done in the year 2020. So that is what I will be speaking about today. To begin with, I'm just going to briefly tell about the AHA chain of survival. There is the in-hospital and the outside hospital chain of survival. The only difference being that in hospital, since the patient is under a monitored care and is already undergoing treatment for something else, it is possible for us to have an early recognition and prevention, as Dr. Megha had mentioned. So it is better to diagnose the preventable causes of cardiac arrest rather than letting the patient progress on to a situation where he might need ACLS. And then the remaining steps remain as they are: activation of the emergency response, a high quality CPR, defibrillation, and post cardiac arrest care to recovery. So I will not be touching much upon the BLS part of it since that's already over. So everyone knows you have to start with the CPR first, then with the oxygenation, and we finally reach a stage where we have to consider defibrillation. So during this, the most important step is recognition of the rhythm. So once you have attached the defibrillator pads or the AED pads, you have to recognize whether the rhythm is shockable or not. So what are the shockable rhythms? They are the ventricular tachycardia. They are usually the tachyarrhythmias. So ventricular tachycardia, monomorphic or polymorphic, and ventricular fibrillation. The unshockable rhythms are the pulseless electrical activity and the asystole. So to give a picture of how they look on the monitor or on the ECG when you do it, ventricular tachycardia is what you see in the upper picture, and ventricular fibrillation, which is more irregular, is seen as in the lower picture. Asystole is total absence of electrical activity, and pulseless electrical activity is where you have to be careful, because when you try to see the rhythm, you might actually get a normal rhythm on the monitor, but this electrical activity is inadequate to actually give the heart adequate contractility, and that's why it's not able to produce a pulse. And without a pulse, as all of us know, there is no use of an electrical activity. So we would consider this as well as a cardiac arrest because there is no perfusion to the brain. So these are the 2020 American Heart Association guidelines for adult cardiac arrest. So as soon as you witness a cardiac arrest, the first thing you have to start with is the BLS without any delay. You give a good CPR with good quality, pushing hard at least 2 inches, minimize interruptions and avoid excessive ventilation. You have to supplement oxygen as soon as possible and attach the monitor or the defibrillator. And then you go for recognition whether the rhythm is shockable or not. Now there are 2 specific protocols over here. So if the rhythm is shockable like a VF or VP, you go ahead and select the maximum shock that is available in your defibrillator, which is, if it's a monophasic, that is 360 joules, or biphasic, there are usually manufacturer recommendations. So they range from 120 to 200 joules. And you can go ahead and shock the patient. And immediately after this shock, without checking for the pulse, you have to continue the CPR again for 2 minutes. And after the first shock is where you go in for an IV or intraosseous access if it already hasn't been established before. Again, after a 2-cycle CPR, check for the rhythm. If again it is shockable, go for the second shock. That is again to the maximum current that can be given, and continue the CPR. What is important over here is after the shock has been delivered, you should not wait to check for the pulse. You have to start CPR immediately, and compressions go at 100 per minute, and ventilation goes on as usual. So the next time you check for a rhythm or pulse has to be after the 2-minute cycle has been completed. And after the second shock has been delivered, now you can consider giving adrenaline, which is a 1 milligram dose, bolus dose, and it is followed by 1 milligram every 3 to 5 minutes. And at this stage, after the second shock, you have to consider going for an advanced airway and capnography if it has been made available by then. Then again, after 2 minutes of CPR, you check for the rhythm. If it is shockable, go again for a shock with the maximum energy that is available. And after this, you can start checking for the rhythm and if there is any signs of return to spontaneous circulation. On the other hand, at the first step itself, if you feel that the rhythm is not shockable, that is an asystole or a pulseless electrical activity, you do not have to shock the patient. The protocol says very clearly that you have to establish an IV access and immediately go for 1 milligram of adrenaline over here, continuing the CPR as it is. And then you have to continue the CPR as has been prescribed for 2 minutes, checking the rhythm every 2 minutes. The moment it becomes shockable rhythm, we revert back to the protocol saying whatever shock has to be delivered. And if it continues to remain non-shockable, we continue with the CPR and the airway management along with checking every 2 minutes. So it's very clear cut and there is no confusion over here. The doses and shock I will be discussing in further slides. So along with all this, you have to be careful. After a cycle of around 3 shocks, that is around 8 to 10 minutes, you have to look for signs of return to spontaneous circulation. So what are the signs? You have to be able to elicit a pulse and a blood pressure. If you have access to capnography, then it would be helpful to see if the EtCO2 shows a sustained rise. And if you have intra-arterial blood pressure monitoring, then spontaneous arterial pressure will give you the signs of return to spontaneous circulation. But if that does not return, then you have to consider after 10 minutes whether you need to continue your resuscitation or you have to stop it. Now, there are different reversible causes acting along with all these things going on. They are usually the 5 H's and 5 T's, but once again, I would say this is a team effort. So everything has to be going on simultaneously. The person who is giving the compressions cannot stop giving compression just because he has to take an IV or has to intubate. So everything has to be delineated in a very systematic way, and the team has to work in coordination with each other. So this is the most important step here. So this is again the protocol, but in a different pattern. It is just showing the cycle of every 2 minutes, what you're supposed to do. And once the 2-minute cycle is over, you again check the rhythm, and it's the same thing in a different pattern. So coming to the treatable causes of cardiac arrest, they are usually the 5 H's and 5 T's, which we have gone through. The hypoxia, hypovolemia, hydrogen ion excess, that is acidosis, hypo or hyperkalemia, and hypothermia. The 5 T's are the tension pneumothorax, cardiac tamponade, toxins, pulmonary thrombosis, and coronary thrombosis. So why these are important is, in spite of the best CPR efforts and in spite of the best resuscitation, if these 10 conditions are not treated simultaneously, it might not improve the scope of your resuscitation, or it might not improve the outcome as far as success of your resuscitative efforts are concerned. So moving on to defibrillation, I will just go through them in brief. So first and foremost during defibrillation is safety of yourself and your team. Because if you shock yourself by mistake, that's like the worst thing that can happen. So you have to stay clear of any contact with the patient, and where possible, self-adhesive defibrillator pads should be used if they are available. Removing any transdermal patches to make the delivery of shock more effective. Do not place the paddles or pads over pacemakers directly, because that will make the delivery ineffective. And most importantly, if you are the person who is delivering the shock, it is your duty to warn other rescuers also to stay clear from the patient. So in brief about the procedure, So the sternal pad, as was explained by Dr. Dheeraj, there are various methods where you can attach, but I am speaking here about the front method. So the sternal pad is on the right side of the sternum, just below the clavicle. Apical pad is in the mid-axillary line, 5th intercostal space. Then once you have placed your pad, switch on the defibrillator and charge it to the maximum current which is available for this. Do a quick visual check whether all are clear from the patient, disconnect any oxygen that might be going in, and warn all clear in clear words and loudly. And then once all are clear, just deliver the shock and immediately restart your CPR without checking for any pulse. Defibrillation, again, biphasic defibrillators give a shock of 120 to 200 joules. Monophasic waveforms can give up to 360 joules. And AEDs have device-specific energy level. What is important here to note is that failure of a single adequate shock to restore a pulse should be continued by followed by continued CPR, and the next shock should be delivered only after 2 minutes of giving CPR. So there is no point in giving repetitive shocks one after the other. It is not going to help in any way. So once you have given the shock, you have to start giving CPR, and only after completion of 2-minute cycle of CPR should we attempt to give the next shock. So that was about defibrillation, and now we go to the airway adjuncts. The basic airway adjuncts are more useful during the BLS because being in the hospital setup or a place where you have to give advanced cardiac life support, you will most probably need to use the advanced airway adjuncts. So advanced airway adjuncts contain supraglottic airway devices or LMA, the laryngeal tube, esophageal tracheal tube or combi tube. These are all used by paramedics, and the endotracheal tube, which is actually the best airway device, which will protect the airway and ensure total safety as well as effective delivery of oxygen, as well as protect against aspiration. But it requires a certain level of expertise to insert an endotracheal tube. So these are just pictures of how you can gauge what size of oropharyngeal airway and how you can insert an oropharyngeal airway or the size of a nasopharyngeal airway. Choosing the size is very important because if you choose a wrong size, you might end up obstructing an already patent airway and making the situation worse. So these are the advanced adjuncts. The supraglottic airway device or laryngeal mask airway has become very, very popular of late because it can be inserted by almost anyone who has learned how to insert it. And it is very safe, provides good oxygenation, good protection against aspiration to a certain level, and is easily available in most of the hospitals. The older adjuncts like laryngeal tube or combi tube were used by paramedics, where the principle was to just blindly insert the tube, and they would have a cuff which could be inflated at the oropharynx, and through openings below the cuff, we could ensure oxygenation to the patient through the larynx. And finally, the endotracheal tube, which I spoke about, we can have cuffed or uncuffed endotracheal tube. They go directly into the trachea and ensure oxygenation. Along with oxygenation, circulation is something we have to be, which is very important for us. And the route of access can either be a peripheral IV cannula, which is more easy to obtain, and you can have 2 or multiple wide bore peripheral IV cannulas, and through which IV fluids as well as drugs can be administered. Alternatively, you can go for a central venous cannulation, but it is more time consuming in spite of the fact that it can probably hasten our IV fluid resuscitation and delivery of drugs, but the amount of expertise and time that is required actually does not favor the ACLS protocol. But of course, where there is no choice and peripheral cannula cannot be obtained, central venous cannulation can be done. Intraosseous route is another route which is especially helpful in the pediatric age group, but it is also useful in adults where no other routes can be accessed. I will not speak much in detail about the drugs as it has already been covered by Dr. Dheeraj, but I will speak about adrenaline, which is one of the most important drugs in resuscitation, since it is the drug which has been incorporated in the 2020 protocol for bradyarrhythmias or cardiac arrest due to bradyarrhythmias. So it's an alpha, beta, and beta 2 stimulator, increases heart rate, stroke volume, and blood pressure. So the dose in ACLS is 1 milligram IV every 3 to 5 minutes. But one caution that you will have to look out for is that it can increase the ischemia, which is already caused to the heart due to an increased oxygen demand. So once you have started giving adrenaline, please make sure that the oxygen delivery to the patient is in place. Amiodarone is again an antiarrhythmic drug, and the doses are 300 milligrams in 20 ml bolus as the first dose, followed by 150 milligrams in 20 ml. After that, you can start an infusion of 1 milligram per minute for 6 hours, followed by 0.5 milligram per minute till a maximum dose of 2 grams per day. Lignocaine, not very popular in today's times, but it was used earlier. With the advent of amiodarone, I don't think many people do use lignocaine now, and mainly because of its toxicity, because it has a dose-related toxicity and it can affect the CNS. So you have to, if you are using lignocaine, you have to look out for signs of toxicity like slurred speech, altered consciousness, and seizures. Other drugs which are used very late in the resuscitation phase are magnesium, propranolol, or esmolol, and sodium bicarbonate. But these are used once you have reached the return of spontaneous circulation to treat the causes which might be causing the cardiac instability. So a little bit about the bradyarrhythmias. Somebody had asked in the questions as for the role of atropine. So this is where atropine actually has a role. So these are arrhythmias. Bradyarrhythmias are typically where the heart rate drops below 50 per minute, but the pulse is present. So with an absent pulse, it's a cardiac arrest, but this is where a pulse is present. So here you have to immediately identify and treat the underlying cause. To maintain a patent airway, oxygen is supplemented if the patient is hypoxemic, cardiac monitor to identify rhythm, and monitor the blood pressure and oximetry. Establish an IV access if it's already not there, and take a 12-lead ECG. But in favor of that, please do not delay therapy just to take a 12-lead ECG. Consider all possible hypoxic and toxicologic causes and start treatment simultaneously. There are 5 questions you have to ask yourself at this time when you encounter a patient with a bradyarrhythmia or a bradycardia. Whether the patient has hypotension, is he acutely altered mental status? Are there any signs of shock? Is there any chest discomfort which might be caused due to an ischemia or a cardiac event? Or is there any acute heart failure? So any signs of these like pulmonary edema and all this should alert you that it is becoming unstable. So you have to give atropine at that point of time. Now in the 2020 American Heart Association, this is the change that they have increased the dose of atropine to a 1 milligram bolus, which has to be repeated every 3 to 5 minutes compared to the 0.5 milligram bolus that was there in the earlier protocol. And the maximum dose is 3 milligrams, after which you have to consider transcutaneous pacing or dopamine or epinephrine infusions if it is ineffective. And Dopamine infusions can usually start from 5 to 20 microgram per kg. They have to be titrated till you get an adequate increase in heart rate. Epinephrine infusions 2 to 10 microgram per minute, titrate as per patient response. Now, the causes for adult bradyarrhythmia with a pulse can be a myocardial ischemia or infarction. Some drugs like calcium channel blockers, beta blockers, or digoxin can cause this, hypoxia, or a electrolyte abnormality like hyperkalemia. So once you have established the cause, we have to take steps towards eliminating those as well, so that your treatment can be more effective. At the other end of the spectrum is the tachyarrhythmia. So basically, it is a heart rate more than 150 per minute, but again, you have the pulse. So that's why it does not qualify as a cardiac arrest, and you need not start CPR. And again, the steps are: maintain a patent airway, assist breathing, give oxygen, cardiac monitors to identify the rhythm, monitor blood pressure and oximetry, get an IV access, and a 12-lead ECG if it is available. The same 5 questions which we had asked ourselves earlier, whether the patient has hypotension, acutely altered mental status, signs of shock, ischemic chest discomfort, or acute heart failure. So if the answer to any of these questions is yes, then you have to go for a synchronized cardioversion in this patient. If you are going for an electric cardioversion, you will have to consider sedation. And if you are going to go for drugs, then you can probably use adenosine, which 6 milligram IV rapid push is the first dose, and the second dose is 12 milligram if required. If they do not show any signs of cardiac instability, then you can take a 12-lead ECG and look at the QRS. If you see a wide QRS of more than 0.12 seconds, then you can consider adenosine or other antiarrhythmic infusions like procainamide or amiodarone IV infusion, so that you can control the heart rate. And if none of these are present, you can go for vagal maneuvers or beta blockers or calcium channel blockers. Always consider expert consultation from a cardiologist, so that the underlying cause can be treated effectively. So now a little bit about ACLS in a maternal cardiac arrest. Now, this is almost similar to the cardiac arrest in adults, except for the fact that here you are dealing with 2 lives. So it has to be a team approach from the beginning. So the team planning should be done in collaboration with the obstetric team, the neonatal team, emergency team, anesthesiology, intensive care. Everyone has to be alerted as soon as you witness a maternal cardiac arrest. The steps go similar to the ACLS protocol, but the most important difference here is displacement of the gravid uterus in order to ensure venous return to the heart. Because if the gravid uterus is compressing on the abdominal vessels, we are not going to be able to deliver effective CPR in spite of the fact that you're giving adequate chest compressions, giving oxygenation, but there is no blood in the upper body. So the first thing you have to do is, along with starting CPR, you have to have a person giving a lateral tilt or manually displacing the gravid uterus. So this is how we can give a lateral tilt. Place the patient on a flat board, and you can insert sheets or pillows to give a 30 degrees tilt. Manual displacement can be given if you have 2 providers. So one person can start the chest compression and the other person can manually tilt the uterus to one side. Then must assemble the maternal cardiac arrest team, consider the etiology of arrest. Usual etiologies in maternal cardiac arrest are either anesthetic complications, excessive bleeding, cardiovascular causes like cardiomyopathy, drugs, embolic phenomena, fever, or general non-obstetric causes, which are the 5 H's and 5 T's that we discussed, or pregnancy-induced hypertension, of course. So perform the maternal interventions in this case. Administer 100% oxygen. Place the IV above the diaphragm if possible. So that will assist you. Once you can infuse IV fluid, it will assist you with the venous return coming to the heart in spite of the gravid uterus. And if the patient has been receiving magnesium for her PIH, then it would be better to discontinue that and supplement with calcium chloride or gluconate. Continue a high quality CPR and defibrillation when indicated. Once you have completed 5 minutes of CPR and there is no return of spontaneous circulation, consider immediate perimortem cesarean delivery, and the neonatal team has to be ready to receive the neonate for resuscitation of the neonate as well. And finally, touching on to pediatric ACLS, once again, it's the same protocol as was followed for adults, with the only difference being in doses and the energy levels of the shock that we give. So once again, if the rhythm is shockable, the first shock has to be around 2 joules per kg, the second shock around 4 joules per kg, and subsequent shocks can be equal to or more than 4 joules per kg, going to a maximum of 10 joules per kg or the adult dose. And CPR continues every 2 minutes after shock, and then you have to reassess the rhythm. In a case of a non-shockable rhythm, you give an epinephrine IV dose of 0.01 milligram per kg, and maximum dose that you can give is 1 milligram. Repeat the dose every 3 to 5 minutes. And if no IV or intraosseous access, you can try giving this endotracheal in a dose of 0.1 milligram per kg. And the other drug, amiodarone, can be given at a rate of 5 milligram per kg bolus, and you may repeat up to 3 total doses. Endotracheal intubation or supraglottic airway can be placed as early as possible in children as they have lesser oxygen reserve, and waveform capnography or capnometry can confirm this. Again, the 5 H's and 5 T's have to be eliminated, and treatment should be in place as early as possible to make your CPR efforts more effective. So I hope I have been able to do justice to this topic, and I'm sure many of these issues will be covered again and again during your workshop. But the most important thing is practice, practice, and practice again, because these protocols will only stay with you if you practice. So the more you revise, the more you repeat, the more workshops you attend, the more ready you will be in a case or a scenario where you will be faced with a situation where you have to revive a patient yourself. Thank you. Thank you, everyone. Any questions?
Thank you, Prasanna. Very, very interesting and very good talk. Thank you very much for that. I'm sure Anshu is also going to cover quite a lot of this again, and I think I'm not going to make any, I'm not going to say sorry for repetitions, because that's how everyone's going to learn. Anshu, if you could just stop sharing your screen for a minute, I will just get on with a few questions and then we can go from there. Okay, just stop sharing your screen and then that should be fine. So I think we've had a few questions which I thought we'll answer at the end of this session. So one of the questions which was asked, which I quickly answered, was they asked why not use noradrenaline instead of adrenaline? Do you have any comments on that?
So noradrenaline would not be a choice here because it has selective beta action. So I don't think its effect on the heart is as much as it is in a peripheral vascular area. So definitely in some place like septic shock, I would probably go ahead and use noradrenaline. But as far as cardiac arrest is concerned, adrenaline is the drug of choice.
Yeah.
There is.
That's right. I mean, I think you had a little slip of tongue. What you were probably trying to say was that noradrenaline is predominantly alpha, so it does not have any beta effect. And
Sorry.
yeah, so it's
Yeah, it has alpha.
yeah, so because you need a beta effect to just get, I think everyone remembers that thing about adrenaline, right? It's a positive chronotrope, inotrope, lucinotrope, and bromotrope. So it's got 4 effects on the beta, and it's the beta 1 action we are interested, because beta 2 action is probably more to do with bronchodilation and a little bit of dilatation in the blood vessels too. But because predominant alpha takes over, and that's the whole idea of actually when we were talking about the principles of resuscitation, is to vasoconstrict everything in the periphery, so you actually get more blood into your central compartment and you are able to pump it. And I can see, because I don't refer to American Heart Association, most of them are now converting to what we've been preaching for years now. Most of them are now in line with what the Resus Council UK guidelines are. Like for bradycardia, we've always been using 1 milligram. I don't know, when 0.5 is a very small dose anyway. It's a piddly dose for someone who's actually bradycardic. Megha, you wanted to say something about this?
Yeah, this adrenaline, why? Because we are here teaching for the masses, where people may not be exposed to the finer aspects of noradrenaline and adrenaline. So it is better to stick to one protocol and let the experts do the job, whether they can use noradrenaline. So when we are teaching for a group, I think it is best to stick to one protocol and then take it from there. Let the experts do the job.
Yes, I completely agree.
I would like to ask one question, if permitted.
Yeah.
What's the role of vasopressin? Means the mixture of vasopressin and adrenaline does it give better results?
No. So so vasopressin was
there are some studies. They say that vasopressin should be considered early in the treatment guideline. So I just wanted to know what's.
So basically, when I did ACLS long back ago, they had vasopressin instead of adrenaline as their treatment, and now they've actually gone to adrenaline from vasopressin. So vasopressin, I think basically there's no point. It is a very specialized drug, right? Now I know a lot of people are using it for myomectomies, this and that. So every place has got some kind of vasopressin available. But still, it's quite a dangerous drug. I mean, of course, if someone's dying, there's nothing, you can't kill someone who's dead, kind of thing. So
they say that there are some studies that they say, means I've come across some studies that they say that it gives better neurological protection. Means brain, if at all it is used early in the. I don't know. So I don't know exactly. That's why I wanted to ask.
So I think the main thing here is, in a specialized center, you may, and there is definitely a school of thought which thinks that. But I think for the purpose of standardizing stuff here, I think we should just go.
True.
Vasopressin was just
the standard.
Now there was a few questions for Megha, which all followed the same question line, and it was like, how harmful is the shock to the person who's administering the shock? As you said, you've experienced it. And another question, which is like, what happens if the CPR provider gets shocked during CPR? I mean, I think for the second question is possibly easier, that you should, if you're a single person resuscitating, then maybe it's time to start praying. But Megha, since you experienced it, why don't you tell us your experience?
So this was a gentleman in ICU who had implanted a cardioverter defibrillator in situ, and he was getting shocks, like it was malfunctioning or something, and he was on table and he started jumping on table. That is why, without realizing he's getting the shock, I touched the patient. So that was very indirect shock, but it was like a huge current that I could feel it in my hand, and immediately, and there was tingling sensation. But God saved me here. Actually, by accident, you yourself can go into ventricular fibrillation, and you may need a CPR in end. So it's not a very pleasant feeling to have it, and it is not advisable. So that is why you particularly ensure that everybody is clear and visually check and then deliver the shock.
Okay. That's fine. I think it's good advice. Very, very good advice. I think, there are two ways you can learn that fire burns. You can actually put your hand in fire and learn it burns, or you can listen to someone who tells you that fire burns. In this instance, I think I'll take advice from you, Megha, and then we make sure that we are very careful when we are defibrillating patients from here on. Another very interesting question which was asked is, what happens if you actually have someone who's got a pacemaker and you need to defibrillate them?
So
Megha?
pacemaker is basically for someone who needs pacing, whose heart is slow, to be in a layman's term. But AED has totally different functions. So maybe in this case, the heart is defibrillating. So that person will still need a AED or a defibrillation, irrespective of the pacemaker. Now, the care you have to take is in the placement of pads, where you're placing the pads. The pad should not be directly placed over where you can feel the implanted pacemaker. Usually it is below the clavicle where you find the implanted pacemaker. So as it is, the placement of pad is never over there. It is above on the sternum and the axilla. So farther away from it, but presence of defibrillator should not, pacemaker should not, stop you from using your AED or defibrillator.
Yeah, it's a good point. I think usually they put pacemakers on the left side, right?
Left
Yeah.
below the.
And usually the pad goes mostly on the right side below the clavicle. And the other thing is that, yes, the one thing which you should know, but still it shouldn't stop, is that once you actually have a pacemaker in situ and you burn someone with electricity, that pacemaker most often will get destroyed. So it will require replacing or it will require to be checked. So if you have had someone who's had a pacemaker in situ, you have defibrillated, the patient has come back, then you would probably have to contact the cardiologist or maybe your cardiac physiologist to come and check the pacemaker. In all probability, if the patient is so pacemaker dependent, normally you might need a temporary pacing wire. So it is not an uncommon scenario. It happens, but as Megha rightly said, the most important thing is actually trying to save the person's life. You can save the pacemaker later. Another question which was there was, I think, precautions in using AED. I think we've addressed that. And then I think if defib machine is available at the same time as adrenaline drug, what should we prefer using first? Prasanna has gone through the whole talk now. So Prasanna, is there any opinion on that?
The uses of a defibrillator and adrenaline are completely opposite. So there has to be no confusion. If the rhythm is shockable, it has to be the defibrillator. It cannot be adrenaline. You will only be worsening it. And if the rhythm is a bradyarrhythmia, where pulseless bradyarrhythmia, then you have to go for adrenaline. Giving a shock to a pulseless bradyarrhythmia is not going to help recovery. Yeah. So that is very clearly mentioned in the protocols, and I think you have to stick to the protocols as far as this goes.
Yeah, I think that's a very good answer. I think there is a very clear pathway between a shockable rhythm and a non-shockable rhythm. But before a shockable rhythm or non-shockable rhythm, and before you come to adrenaline defibrillation, the main thing is to start chest compressions. There is nothing more important than that. Start with chest compression, come and put on some pads, and after the pads is put on, you can actually then decide what you have to do. If it's a pulseless electrical activity or asystole, start with adrenaline. If it's a shockable rhythm, shock. It's as simple as that, right? There's another question which is on bradycardic arrest in spinal anesthesia patient. Well, let's do the next talk and then talk about bradycardia. In places where there is no defibrillator, how effective is the pharmacological management of shockable rhythms? I think, if you have amiodarone but don't have a defibrillator, I would probably go and talk to the hospital management first, because I think it'd probably be the other way around. But if you don't have, and you just have a syringe of amiodarone and you've put an ECG and you find that the patient has pulseless VT or VF, you can give the amiodarone. There's no harm, right? And by the time then the defibrillator comes from somewhere, you can do it. But I don't think so you'll find it as effective, because we do use it quite often in a lot of patients who have arrhythmias in ITU, and we do find in septic patients fast AF, we give amiodarone. It takes quite some time to kick in to actually, it only does rate control. It doesn't cardiovert everyone. So there are two ways amiodarone acts. One is in some patients you use it for rate control, and some it actually chemically cardioverts. It's not to say that everyone will chemically cardiovert, but I think it's a very interesting question, Arnold. I think I would probably, if I have nothing, I'll probably give it. Anything. You're in a situation which the patient's going to die anyway, so use whatever you have in hand. So I think Anshu has been waiting very patiently. My apologies. I think we are slightly running over time, but that doesn't matter. And I think we're having a very good discussion. So if you want to introduce yourself and start your talk, I'll be grateful. Thank you.
Am I audible?
Yes, you are audible here, and I can see your slides too. Thank you.
Yeah. Just a minute. So today I'm going to talk about peri-arrest scenarios. First of all, about myself, I am Dr. Anshu. I am professor in Lady Hardinge Medical College and associated hospitals in Delhi, and I am a AHA certified ACLS and BLS instructor. So I'll be talking about peri-arrest situations. These situations are very much emphasized by AHA also, and they are very, very important to recognize and treat these situations, because peri-arrest means these are the situations just prior to the arrest or just after the arrest. So whenever there is any physiological condition, whenever someone is sick, admitted in the hospital and about to go in arrest, there are some recognizable physiological changes which needs to be identified and corrected. And if with good assessment skills and intervention, if intervened, then there might be that we are able to prevent the arrest also. So there's a lot of emphasis that these peri-arrest situations needs to be identified correctly and treated very promptly. So I'll be discussing bradyarrhythmias, tachyarrhythmias, and near fatal asthmas in my talk. Dr. Prasanna has though already discussed bradyarrhythmias. I'll be taking up these in further details. Now, what is bradycardia? Whenever heart rate is less than 60 per minute, we call the patient to be having bradycardia. Bradycardia is synonymous with bradyarrhythmia. Both the terms are synonymous. Bradycardia is said to be symptomatic when heart rate is less than 60 per minute, that is eliciting signs and symptoms. Signs and symptoms may be chest discomfort, lightheadedness, dizziness, pre-syncope or syncope. Excuse me. Now, symptomatic bradycardia, therefore, we call it symptomatic when the heart rate is slow, patient has symptoms, and the symptoms are attributed to the slow heart rate. Now, bradyarrhythmias, they include sinus bradycardias, first degree atrioventricular blocks, second degree atrioventricular blocks, and third degree atrioventricular block or the complete block. Now, for treating these conditions, we should also know how to identify on the monitor and treat them accordingly. Because as previously also discussed in the algorithm, you need to identify whether the bradycardia is symptomatic, asymptomatic, stable, unstable, and what kind of bradycardia it is, so that you can treat accordingly. So coming on to sinus bradycardia, you can see the ECG. This is ECG of sinus bradycardia, where there is a P wave, and every P wave is followed by a QRS complex. Only the heart rate, which is less than 60, is there, but the complexes are absolutely normal. PR interval is normal, and every P wave is followed by a QRS complex. Now we have another type of bradycardias, atrioventricular blocks. It is further categorized into first degree AV block. What happens in first degree AV block is that there is slow conduction from atria to the ventricles, though all impulses are conducted to the ventricles. Now, due to slow conduction from atria to ventricles, there is prolonged PR interval, which is greater than 0.20 seconds, that is more than 3 small squares. So in first degree block, there is a prolonged PR interval which is fixed, and P wave is always preceded by QRS complexes. These patients are mostly asymptomatic. Then we have second degree AV block, which is further categorized into morbids type 1 and type 2. There is in second degree, there is intermittent failure of conduction from the atria to the ventricles. Now in type 1, there is a block at the level of AV node. So what happens is that there is increase in PR interval, which is progressive in nature, and it keeps on progressing until there is a failure to conduct to the ventricles. This is Wenckebach's phenomena. These are also mostly asymptomatic or mild, or they are less dangerous, we can say. But morbids type 2, in them the block is below the AV level. So because the block is below the AV node, the PR interval is fixed. PR interval is normal, but every P wave is not followed by QRS complex. So there is a fixed normal PR interval with intermittent dropped QRS complexes. You can see in the ECG also that the rhythm is not regular, and every P wave is not followed by QRS complexes. There are missed QRS complexes in the ECG, but PR interval is absolutely normal and fixed. Then we have third degree AV block, which is complete AV dissociation. There is complete failure of conduction from atria to the ventricles. Here the block may be at the AV node, bundle of His, and bundle branches. So what happens is that P wave is present, but every P wave is not followed by QRS complexes, and the QRS because the block is, there is failure of conduction from atria to ventricle, there are missed QRS complexes, and QRS complexes are fixed and are wide and at fixed intervals. So you can see that they are occurring at fixed intervals, but they are wide complexes. And PR interval is absent because in some cases there may not be any QRS complex, so PR interval may be absent also. These patients are hemodynamically unstable and might require artificial pacemaker also. So first degree heart block and second degree type 1 heart blocks are the ones which are mild, asymptomatic, but type 2 and third degree, they will be requiring cardioversion mostly, and they are mostly of the unstable types. These are the ECGs just for remembering purpose. You can see that this is the first degree AV block with the prolonged AV intervals, and every P wave is followed by a QRS complex, and QRS complexes are at the regular intervals. Then this is the second degree block in which type 1 is there, where there is a prolongation of the PR interval is seen, and every P wave is followed by a QRS complex. Then second degree type 2, in which there is fixed PR interval, which is normal, and every P wave is not followed by a QRS complex. And then comes the third degree, in which there is complete AV dissociation. P wave is not followed by QRS complex, and QRS complexes are wide complexes. Now, how do we treat bradyarrhythmias? First of all, we have to assess the appropriateness of clinical condition. When I say what do I mean by appropriateness of clinical condition? Appropriateness means that every patient who is having heart rate below 50 per minute may not be having bradyarrhythmia. Why? Because suppose if it is an athlete whose vagal tone is already down, so he may have a heart rate of 40, which may be absolutely normal for him. So take a proper history and consider the appropriateness of clinical condition, and then proceed for the further. Whenever we have a patient with bradycardia, after we have assessed that actually it is a bradycardia, then we have to identify and treat the underlying causes. Remember, peri-arrest scenarios, these are the patients who have some cause, underlying cause, which can be identified and treated. Actually, we are not treating the rhythms, but we are treating the patient and the underlying conditions. So always remember 5H and 5Ts in mind and start working on them simultaneously. Whenever we have bradyarrhythmia, we have to do a primary BLS survey and followed by a secondary ACLS survey. We have to maintain ABC, airway, breathing and circulation, maintain a patent airway and assist breathing. Oxygen is to be given and apply 12-lead ECG and establish an IV line and consider the possible causes. Now, after you have done primary BLS and ACLS survey, then we have to see that whether patient is stable or unstable. If patient is stable, then we have to monitor and observe. But if it is an unstable patient, unstable, what do I mean by unstable patient? Means that patient is having hypotension, any altered mental status, dizziness, any signs of shock, there is some chest discomfort, chest pain, then we have to consider that there is some problem and the patient is becoming unstable. So when patient is unstable, we need to give atropine. Now, newer guidelines, 2020 guidelines say that in previous guidelines, atropine dose was different, but now you say that you give first dose of 1 milligram bolus, and if not treated by this, you give another 1 milligram bolus dose after 3 to 5 minutes, followed by the third dose. So maximum you can give up to 3 milligram or 3 doses. Now, if not treated by this, then you can start dopamine infusion, which is again, there is a change in rate. Earlier it was 2 to 20 microgram per minute, but now you give at the rate of 5 to 20 microgram per minute and you titrate to the patient's response. It is AHA says that there is no difference in dopamine or epinephrine. You can start either of them. Either you can give dopamine or epinephrine. Epinephrine is given in the rate of 2 to 10 microgram per minute infusion and again titrated according to the patient's condition. And if it is still not treated, then do not hesitate to consult the experts, call the experts for help and prepare in the meantime for the transvenous pacing. And besides giving the drugs and treating the patient, look for the causes, like there can be myocardial ischemia, drugs, some toxicological causes, hypoxia, or any electrolyte abnormalities might be there underlying. So moving on to the next topic, tachyarrhythmias. We call a patient to be having tachyarrhythmia when heart rate is more than 100 per minute. Now, again, it is important to identify the tachyarrhythmias so that we can treat them accordingly. Tachyarrhythmias can be narrow complex or broad complex. Narrow complex are when the QRS duration is less than 0.12 seconds, and when QRS duration is more than 0.12 seconds, it is broad complex tachycardias. Narrow complex can be supraventricular, and wide complex are mostly ventricular tachycardia, or it can be a W syndrome, or it can be a supraventricular tachycardia with a bundle branch block. So this is an ECG of sinus tachycardia where you can see there is tachycardia, but every P wave is followed by a QRS complex, and QRS complexes are absolutely normal. Now coming on to narrow complex tachycardias. Narrow complex tachycardias are the supraventricular tachycardias, which arise above the level of bundle of His. Now we have paroxysmal supraventricular tachycardias under this. Then it can be atrial fibrillation, flutter, or Wolff-Parkinson-White syndrome, or WPW syndrome. Now PSVT, usually the heart rate is 150 to 180 per minute, and there are narrow complexes you can see which are less than 3 small squares, that is 0.12 seconds. Each small square is 0.04 second. So 3 small squares, 0.12 seconds. So it's easy to quickly identify if you look at the squares. And there are no P waves. You can see there are no P waves present in this narrow complex tachycardias. Then atrial fibrillation or irregular rhythm. There are no P waves and there is absence of isoelectric baseline, and there is a variable ventricular rate. Now these fibrillative waves may be present and can either be fine with amplitude less than 0.5 mm or coarse with amplitude greater than 0.5 mm. WPW syndrome, it is characterized by presence of accessory pathway or there is a bypass tract. So what happens is that there is a bypass tract which connects electrical system of atria directly to the ventricles, allowing conduction to bypass the without bypassing through the AV node. So there is a short PR interval and there is a delta wave which is slightly slurring of the upstroke of QRS complex. So this is how you identify the WPW syndrome. Then we have wide complex tachycardia, that is VT. Wide complex tachycardia, now VT it can be monomorphic or polymorphic. The monomorphic are the ones which have QRS complexes which are single stable of same morphology and there is no beat to beat variations. These are usually stable tachycardias, monomorphic, and if unstable, they are treated with synchronized cardioversion. But polymorphic are the ones which have beat-to-beat variation in the morphology, and they are mostly the unstable ones, and they require unsynchronized cardioversion. Coming on to the adult tachycardia algorithm, whenever we have a patient who is having tachycardia and having a pulse too, that means that there is a danger that patient might revert back to normal if treated appropriately or may go into VT and VF and in a pulseless VT and VF. As ma'am has discussed, Dr. Prasanna has already discussed VT, VF management, pulseless VF, VT. So I'll be taking up what to do with the patient with pulse, with tachycardia. Again, you identify with the appropriateness of the clinical condition and then proceed with the tachycardia. Now, remember that you have to perform a primary BLS survey followed by a secondary ACLS survey. Maintain airway, breathing and circulation. Give oxygen to the patient. Attach ECG monitor, monitor BP and pulse oximetry, and secure a IV line so that drugs can be given accordingly. Now, again, we have to identify whether the tachycardia is stable or unstable. If patient is having hypotension, altered mental state, there is shock, chest discomfort, or there is heart failure signs, then the patient is unstable. But if there are no such signs and symptoms, that means patient is having tachycardia, but the patient is stable. Now remember, whenever we have a patient with stable tachycardia, our whole emphasis lies on, first of all, we have to identify the underlying cause and treat accordingly. Besides that, we will see whether it is wide QRS complex or a narrow QRS complex. If it is not a wide complex, it is a narrow complex QRS complex, then what it can be? These are supraventricular tachycardias, which can be a PSVT or other type of tachycardias we have discussed. So first step is that we give vagal maneuver. Vagal maneuver can be given either by asking the patient to perform the Valsalva or giving a carotid sinus massage. Whenever carotid sinus massage is given, remember that it should not be given at the both sides simultaneously, and also ask whenever you receive such a patient, you see such a patient, also ask about the history. If there is any history of previous such episodes and how they get terminated, because PSVT patients, they usually have a history of such episodes, and patient himself or herself tells that when treated with carotid sinus massage, the attack gets terminated. So it will be helpful in the management. Then you can, if vagal maneuver is not effective, then adenosine is given. Now adenosine is given in the dose of 6 milligram, which is followed by a dose of 12 milligram after 1 minute. And again, if not diverted by this, then again we can repeat 12 milligram after 1 minute. Now regarding adenosine, remember that it is to be given in large antecubital vein, and it is to be given it has to be given very fast. So it is given by a 2 syringe technique 2 syringes are attached to the vein. With one syringe, you push the drug, with another, you push the saline bolus, and you raise the arm for 30 seconds. Then if adenosine is not effective, then one can go for if adenosine is not effective, or you get these arrhythmia get reverted back, then treat with the longer acting drugs like beta blockers or calcium channel blocker like diltiazem. Just a minute. I'm sorry for the interruption. Yeah. So if adenosine is not effective, go for IV longer acting drugs like beta blocker or calcium channel blocker. And in the meantime, also call for help and consider expert consultation. Now, what if they are not stable? If tachycardia is not stable, then the immediate answer is synchronized cardioversion. One has to give synchronized cardioversion. What is synchronized cardioversion? In synchronized cardioversion, when you in the machine, when you press the shock button and you put it on the synchronized mode, the sensor senses the QRS wave, QRS part of the wave of the ECG, and synchronize the shock with the QRS wave, so that there is a synchronized shock. And remember, whenever you give synchronized shock, consider sedation to the patient. But if you feel that patient is getting unstable, very unstable, then do not wait for the sedation and immediately give synchronized cardioversion without shock. If the complexes are regular, narrow complex, then you might consider adenosine. If these are refractory, then you have to consider the underlying causes. In any case, you have to simultaneously keep working on the underlying causes, and you can consider the addition of antiarrhythmic drugs and seek for the expert consultation. What antiarrhythmic drugs we can give? If cardioversion is not effective, then we can go for the we have to consider the antiarrhythmic drugs also. And for stable tachycardias, stable wide complex QRS tachycardias also, we have to give antiarrhythmic drugs, which is procainamide, which is given in the IV dose of 20 to 50 milligram per minute infusion, which is given until there is 50% increase in the QRS duration, or which has to be stopped, not to be stopped until there is QRS duration increase more than 50% or there is any hypotension. We can give maximum dose of 17 milligram per kg and maintenance infusion dose is 1 to 4 milligram per minute, and avoid if there is QT prolongation. We can either give procainamide or amiodarone IV in the dose of 150 milligram over 10 seconds and repeat if ventricular tachycardia occurs, or sotalolol can be given if there is not prolonged QT interval, which is given in the dose of 100 milligram over 5 minutes. So I'll just summarize that if it is a tachycardia and if it is stable, then you see whether it is a wide complex or a narrow complex. If it is a narrow complex tachycardia, then go for vagal maneuvers. If not resolved, go for adenosine, and you can start beta blocker or calcium channel blockers and seek for help if not yet reverted. If it is a stable tachycardia and a wide complex tachycardia, then you give adenosine if it is regular and monomorphic, and otherwise you consider for antiarrhythmic infusions. Antiarrhythmic infusions which we can give are procainamide IV or amiodarone or sotalol. Procainamide is given in 20 to 50 milligram per minute, but you have to reduce the dose if there is QRS duration increases more than 50%. Then if it is a tachycardia which is unstable, then immediately prepare for synchronized cardioversion and consider sedation. Also treat the underlying cause and consider starting the antiarrhythmic drugs. Here also remember that if it is a Morbid's type, second degree Morbid's type 2 or a third degree tachycardia, even if it is you are finding it to be stable, you prepare for cardioversion because they are dangerous rhythms and anytime they might convert into a complete heart block, and patient might require cardioversion. Excuse me. Now, I have included few scenarios so that it brings the more clarity of the concepts. Now, if you have a 80-year-old patient with CAD taken up in operation theatre for THR under subarachnoid block, and suddenly patient complains of chest discomfort after 40 minutes. The heart rate is found to be 40 per minute and BP is 80/50. I think someone has asked this question also. So what will you see in this case? This is a patient of bradycardia. A bradycardia is there, but you can see the underlying causes that subarachnoid, it is after 40 minutes of subarachnoid block, so probably subarachnoid block is not the cause. And you can see the ECG that there is a bradycardia, which is a atrioventricular block. Which type of block? You can see that there is a bradycardia with PR interval which is fixed and normal, and there is a irregular QRS complexes. So it is probably second degree type 2, and patient is getting unstable with pulse of 40 per minute and BP of 80/50 per minute. So what will you do? You will treat it with injection atropine. Coming on to the algorithm, you can see sorry. So what does the algorithm says? That it is atropine we will give first dose 1 milligram bolus repeated every 3 to 5 seconds. And if not treated, then we have to start with dopamine or epinephrine. So coming on to the next scenario, where there is a 20-year-old female in pulmonary edema with severe MS, CS done under GA and not reversed. Post-operatively, patient is having heart rate of 160 per minute and BP of 70 to 30 mmHg. Now you can see this is a supraventricular tachycardia. Here, patient is unstable with heart rate 160 and BP is 70/30 per minute. So what we have to do in this case is that we have to prepare for cardioversion. Then we have a 50-year-old male patient with sepsis on ventilator. Patient is with pulse. Patient has pulse with tachycardia, BP of 60/40 per mmHg. We have a monitor showing ventricular tachycardia rhythm. How will you proceed? So this is a VT which is getting unstable. So again, the answer is that we have to proceed for the cardioversion. Now coming on to near fatal asthma, patient is normally near fatal asthmas are the conditions which can anytime become fatal, and patient will not give you much time to treat. So whenever you find a patient with wheezing, always remember that oxygen saturation levels may not reflect the progressive alveolar hypotension. You supplement with oxygen and titrate to maintain the saturation level of greater than 92%. Then one has to give inhaled beta-2 agonist albuterol, which have the effect of bronchodilation with minimal side effects. Dose of inhaled salbutamol by nebulizer is 2.5 to 5 milligram every 15 to 20 minutes, intermittently or continuously at the rate of 10 to 15, or continuous at the rate of 10 to 15 milligram per hour. Then one can go for corticosteroids, but these show effect after 6 to 12 hours, but these are the only drugs which have anti-inflammatory effect and must have to be added to the regime, but though they may not be effective acutely in the condition. IV route is preferable because patient may vomit or unable to swallow. Dose given is 125 milligram IV. Then one has to give adjunctive therapies like anticholinergics. Again, it has got slow onset of action with peak effect which comes at 60 to 90 per minute, and the nebulizer dose is 0.5 milligram. Magnesium sulfate can be given as an adjunctive therapy. IV magnesium sulfate improves the pulmonary function and dose is 1.2 to 2 gram IV over 20 minutes. Then one can give parenteral epinephrine or terbutaline in case of severe asthma, which is not getting reverted. So the dose is of subcutaneous epinephrine 1:1000 is 0.01 mg per kg divided in 3 doses of approximately 0.3 milligram given at 20 minutes interval. One can give terbutaline also if epinephrine is not available, 0.25 milligram subcutaneously, which can be repeated in 30 to 60 minutes. Then another adjunctive therapy which can be given is helium and oxygen mixture in the mixture of 70:30 of helium is to oxygen, which is less viscous than ambient air. But the limitation of heliox is that you require at least 70% helium for the effect. So if patient is requiring more than 30% of oxygen, then heliox mixture may not be effective. So thank you, and I hope I have done justice to the topic and you are able to understand it in a better way. Thank you so much.
Well, thank you very much. That was a very good talk, Anshu, and your examples were very good, so people could actually understand what they were doing. Very, very good. And I think we're just running late. There are a few points which we need to make on, like what I was telling previously, that 1 milligram is what you said is the thing which is done in the American Heart Association guidelines. The UK guidelines still says 500 mics. It doesn't say 1 milligram, but it depends on what kind of bradycardia it is. The other difference which they have is that in Americans, they actually say start using dopamine, whereas in the UK guidelines, we use isoprenaline. So there is no right or wrong answer. Isoprenaline is also an agent which could be used. There are other special considerations you may need to think. For example, they say if your bradycardia is more due to inferior wall MI or a spinal cord injury, or if you have a transplanted heart in situ, with that bradycardia, the agent of choice then is aminophylline, and aminophylline works very well in those kind of bradycardias. You also have bradycardia which could be induced due to poisoning like beta blockers or calcium channel blockers, in which case glucagon is going to be the only agent which will work in those kind of patients, and you might find giving glucagon is more useful in that. But these are all variations, and these are just some special tips. If people want to learn a little more, they can go to the Resus Council UK. There's much more on bradycardia which is mentioned there. And I think there are a couple of questions, but these are general questions, and I think I'll put it to the Q&A session in the end. So we can start with the next talk. Thank you, Anshu. Thank you very much.
Thank you, sir.
Sudipta, are you ready?
Hi. Yes, sir. I'm ready.
I think I'm also looking forward to this talk, which is, I think Sudipta has been very kind to actually do a talk on echoes and cardiac arrest. Sudipta, if you want to introduce yourself, share your screen and go ahead with the talk, that'll be great.
Hello. Good afternoon, everyone. Am I audible?
Yes, you are.
Good afternoon, and thank you, sir, for giving me the opportunity and involving me in this excellent academic program. And ECHO is always very close to my heart, and whenever I get any topic related to focus on ECHO, I try to grab it. It gives a huge learning during preparing for the talk. So in next 20-25 minutes, we will talk about ECHO in cardiac arrest. Myself, Dr. Sudipta Mukherjee. I work as a critical care consultant in Tata Medical Center, Calcutta. It's a dedicated tertiary care cancer hospital. So we'll start with a case. It's a 68-year-old lady, uncontrolled diabetes and obstructive sleep apnea. It has carcinoma ovary and received chemotherapy just recent past. Now she is admitted within the ward with some occasional fever and shortness of breath. She received some non-invasive ventilation just to decrease the work of breathing. And also he was getting intermittently CPAP at home because of OSA during sleep. So the on-duty doctor sent some blood and urine investigation and did a chest X-ray. You can see the chest X-ray. It looks reasonably okay. On day 2, patient had sudden cardiac arrest. Code blue was activated. We really do not know what exactly happened. The code blue team reached, CPR given as per ACLS protocol, and ROC was achieved after 2-3 cycles of CPR. And the patient was immediately shifted to ICU. And he got intubated, ventilated, AFI to 100%. He was in shock, requiring high dose of noradrenaline and vasopressin. And during this process, she again developed another arrest. And the ECG we did shows a asystole. You can see the ECG in the screen. So how to proceed for the management of these patients? The standard protocols we all know, so there is no rocket science in that, but what we can evaluate, we can go through in next 20-25 minutes, that can echocardiography help us to get a better diagnosis and also in terms of management. So yes, if you look at the present literature, echocardiography can help us both in terms of diagnosis and also in terms of prognostication. For diagnosis, it can help us to diagnose the type of cardiac arrest. There are times it is very difficult to differentiate between a true asystole from a fine VF. The ECG, we know that when we do an ECG and we get a flat line, the standard technique is you should see the connection is present in both ends, then you increase the gain to differentiate between an asystole and fine VF. But if you have an access to echo, you look at the heart, you can easily identify whether there is any other electrical myocardial contractility present or not. It may found a small flittering type of movement present in the myocardium. Along with the change in treatment, it also has a prognostic value because during any asystole, if the patient has some amount of cardiac activity, they usually do better in terms of the final outcome. Besides this, echocardiography significantly helps us to identify the underlying cause and its treatment, that is the correctable factor. So whenever we get patients with a cardiac arrest with a non-defibrillable rhythm, we focus on the reversible causes, and echo can help us to diagnose different underlying causes like acute coronary syndrome, cardiac tamponade, pulmonary embolism, tension pneumothorax, and hypovolemia. Hypovolemia means, I want to say, in a certain trauma scenario, there may be a sudden bleed, or it may be a reaction between the immediate postoperative status, which leads to a severe hypovolemia and leading to cardiac arrest. And also, whenever we are addressing these reversible factors, echocardiography or ultrasound can help us to do the necessary procedures like thoracotomy or pericardiocentesis. For prognostication, yes, echocardiography can help to pick up the quality of CPR. We can be done by a real-time evaluation of the quality of compression by transesophageal echo. Also, it can help us for the monitoring of the interventions and the response to the patient with our interventions. And as I mentioned, if some amount of cardiac activity is there, cardiac contractility is present, they have a better outcome. So identifying those movements, identify those cardiac contractility, help us to continue our CPR to provide better ROAC and survival in due course. But whenever we do using focus in a cardiac arrest scenario, there are few factors we need to keep in our mind. The biggest concern is that are we going to interfere in the resuscitation process, which is very, very important and a very protocolized system in a cardiac arrest scenario. But it has its own flip side that if there is a reversible factor, unless we identify it and address it, there is a very less chance that patient will reverse. The cardiac arrest will reverse and patient will gain a ROAC. So during using focus in a cardiac arrest scenario, we have to keep some factors in mind. Like the time, maybe it should be really less for evaluation. It should be less than 10 seconds. It should not interfere with the resuscitation as much as possible. Should be done by the most expert ultrasound clinician because there is significant time pressure. And whatever the window we are using, we should stay away from the compression zone. So our first choice is usually subxiphoid. We should look at the heart and also at the IVC. If somehow it is not possible, then you look at parasternal long axis and apical fourth chamber. Both transthoracic and transesophageal can be used, but I think most of us have, in this type of scenario, have an access to transthoracic. And the concern regarding delay in restart of compression and interruption in the resuscitation process will always be there in our mind. Now, whenever we are looking at an echocardiography and a cardiac arrest scenario, what we want to see? Want to see any visible movement of the myocardium is present or not. As I mentioned, the diagnosis, differential diagnosis is basically an asystole and a fine VF. Studies have shown that patient who has come to the emergency for out-of-hospital cardiac arrest, around 30 to 35% of those patients has a demonstrable cardiac contraction. Now, if this cardiac movement is because of fine ventricular fibrillation, then the treatment is defibrillation. Even if these are not because of defibrillation, usually these patients there is justification to continue prolonged CPR in these patients because they usually have a better outcome. And so the time frame that we have discussed in our previous presentation, that once there after 20 minutes the CPR, when the cardiac ROC is not coming back, then probably we have to decide how long should we continue. But in this context, if there is a certain cardiac movement, myocardial movement is present on echocardiography, there is a logic to continue resuscitation in a certain subgroup of patients. In this video, you can see that there are a fine filtering movement that happening is near the septum of the heart. And do we have data? Yes, we have. This is recent study which incorporated 793 patients of out-of-hospital cardiac arrest who was admitted with non-defibrillable rhythm. And it shows that nearly 33% of this patient has certain amount of cardiac activity. And these patients has a significantly better outcome in terms of return of spontaneous circulation, survival at hospital admission, and also a discharge at hospital admission. So in this subgroup, it is logical to continue CPR, prolong CPR beyond the conventional time limit. Even in this meta-analysis, which incorporated 8 studies of 568 patients with cardiac arrest, it shows there is a low probability of ROAC and survival when there is no cardiac activity detected on admission. And ROAC rate usually poor if there is an electromechanical dissociation. That if there is a certain electrical activity is going on, and if you do an echo, you find there is an assistance. Usually there is a delay in picking up with these patients, and probably that is the reason of having a poor outcome in this subgroup. And this meta-analysis also shown that ultrasound can be continued in a CPR scenario without interfering. It can contribute to the differential diagnosis of the patients and also help us to identify the underlying cause, giving leads to better prognosis. This is one of the structured protocol that has been developed specifically for cardiac arrest scenario. It's called FEAR protocol. And if you look at this, the windows for the probe has consciously kept away from the compression zone, and it has been started with the subxiphoid. If you're not getting satisfactory window, only then we are going to apical and parasternal. And at the same time, beyond that CASA protocol, that is cardiac arrest sonographic protocol, if we are trained enough and we have time margin or have enough manpower, we can extend it to echo class. That means we can evaluate other areas of the body with the help of focus concept and try to identify the other reversible factors. So we can look in a very fast manner. Like we can look at the airway to see whether the tube is in place or not. Maybe anterior part of the chest to rule out any pneumothorax. Base of the lung and abdomen in case of trauma when you are suspecting a massive bleeding. And maybe a very fast lower limb venous scan to rule out thrombus, deep venous thrombosis leading to pulmonary embolism. And how we can incorporate this echocardiography during a continuous CPR process, that we will continue CPR as per our standard ACLS protocol. Whenever we are taking a break to give true ventilation, at that time, within a time frame of 10 seconds, we have to do the echocardiography. And the suggestion is that we should not try to evaluate or interpret the finding. We just should try to get the picture of the heart and also at the IVC. Now, when the second cycle of CPR will be started, then we have enough time to evaluate our recording and to take necessary clinical decision. What are the findings we can expect in a cardiac arrest scenario? We know that what are the reversible factors. So probably in a cardiac tamponade background, we can get a pericardial effusion with a plethoric IVC. In hypovolemia, we'll get obliterated ventricle, that is the chambers are empty, maybe IVC inferior vena cava is collapsed. In case of pulmonary embolism, if we are lucky, we may get a right heart thrombus, both in maybe in atrium or in the ventricle. Right ventricle may be dilated. We may get a D sign of the left ventricle and deep venous thrombosis. And in tension pneumothorax, probably there is an absent lance lining, even with a ventilation. Now let's come back to our case. This patient got an ROAC achieved after 4 cycles of CPR, but the shock worsened, requiring noradrenaline, vasopressin, and adrenaline with a very high dose. And the patient is on ventilator with 100% oxygen, sedated, paralyzed. With this blood pressure, SpO2 is not picking up. ABG showing severe metabolic and respiratory acidosis. ECG showing sinus with a heart rate of 140. And the supportive medical management is continuing. Now, can echocardiography help in this scenario to identify the reversible causes that is present in a pericardiac arrest condition, like 5H and 5 that we all are aware. Among that, the four components of the T, that is the cardiac tamponade, tension pneumothorax, pulmonary thrombosis, and coronary thrombosis, can be identified with the help of echocardiography. And also sometimes with an extended echocardiography, that is by the application of focus, we can also identify the cause of hypoxia in certain situations. And let's see how echocardiography of focus can help us in this context. There are multiple protocols present in this present literature that how we should approach a pericardiac arrest patients. Doesn't matter in which protocol you follow, most of them, the basic physiological understanding is same. And as I mentioned, that along with your conventional echocardiography, if you have the expertise and the facility, you can extend it, like maybe an assessment of the airway to confirm that the ET tube is in position, lung scan to rule out any pneumothorax or any intrapleural bleeding, interpleural space bleeding, abdominal scan to rule out intra-abdominal bleed, and a lower limb venous Doppler to rule out deep venous thrombosis. Can we identify chronic cardiac condition? Because in this type of situation, if the patient has already have an underlying heart disease, chances of recovery become worse. Even we do not able to identify what is the underlying pathology, but there are certain findings in our routine echo which will suggest the patient has an underlying heart disease. Like the left ventricle, left atrium chambers are dilated, left ventricle is thickened, right atrium is dilated. Right ventricle is the only chamber in the heart that can dilate acutely. So from that, we cannot comment that whether it's acute or chronic. But if we find that the right ventricle is thickened, that the wall thickness is more than 5.5 centimeter, it indicates that is the underlying chronic pathology. So by this, we can conclude that whether this is an acute problem or there is an acute or chronic problem that happens with our patients, and it eventually influences the prognosis. Now let's look at the hypokinesia. Most of the time, when you are in a post-cardiac arrest scenario, there is a certain amount of compromise in the cardiac contractility. Most of the time, it depends on the duration of the CPR. Like in the left picture, you can see there is a significant compromise in the cardiac contractility. Now, for these patients, we need an inotrope to improve the tissue perfusion. Otherwise, there will be this severe metabolic acidosis is not going to be correct. So you can see echocardiography can guide us in terms of our medical management. And in our right case, we can see there is an ordering stress cardiomyopathy present. We can see a Takatsugi pattern that the base is moving contractile well with an apical ballooning. So eventually, it helps us to diagnose what is the underlying pathology that leads to this acute condition. In case of acute coronary syndrome, we will get a regional wall motion abnormality. And the regional wall motion abnormality will guide us towards the vessel that is at stake, that has been blocked, or is the culprit vessel. So that can, like in our in this picture from the parasternal short axis view, you can easily say when if the inferior wall is involved, then that's probably an RCA. If the septum is involved, then it's an LAD. The lateral wall is involved, probably that means circumflex vessel that is at stake or that has been got thrombosed. Now, these patients mostly will be in severe hypoxia. So with our lung scan, we can see whether this hypoxia is primarily because of the cardiac problem, or the cardiac or the hypoxia that the lung is the primary problem that leads to this cardiac event. We all know that normally we get an A pattern in the lung, and when there is an decrease in the aeration, that is increased fluid in the lung, we'll get B pattern. Now, whether it is a cardiac related pulmonary edema or a non-cardiac, that we can easily differentiate. Because in case of cardiac pathology, the lung pulmonary edema will be homogeneous. It will show gravitational distribution. The pleural line will be smooth because there is no underlying lung pathology, and there should not be any subpleural consolidation. So you can clearly identify in the right pictures that there is an underlying lung pathology that leads to hypoxia, and probably that is the cause of cardiac dysfunction in the patient. Next will be the pericardial tamponade. Now, what are the echocardiographic findings we can expect? That there will be pericardial effusion, but only pericardial effusion does not diagnose a pericardial tamponade. Also, we can see plethoric IVC, and the classical finding is called systolic collapse of the right atrium and diastolic collapse of the right ventricle. Now, from this picture, we can easily identify there is a diastolic collapse of the right ventricle and a systolic collapse of the right atrium with a significant amount of fluid. But we need to remember that the amount of fluid in the pericardial space is not the diagnostic marker for pericardial tamponade. It is the rapidity with which fluid is collected. Tamponade physiological parameters can be developed even with a small volume of fluid in the pericardial space. Next, etiology that can develop an acute event, acute cardiac arrest, is pulmonary edema. We all know a significant number of patients who landing to the emergency with a sudden cardiac death are because of pulmonary edema, because of pulmonary embolism. So whenever we are looking at echo in this type of patients, if the pulmonary embolism leading to a cardiac arrest, you will definitely get a right ventricular dysfunction. What we can see in the left ventricle, we can get a D-shaped left ventricle. Because of the raised pressure in the right ventricle, the septum will be shifted to the left side and you will get a D-shaped ventricle. And if you focus on the right side, you can clearly see the right ventricle and right atriums are dilated. There is a paradoxical septal systolic movement and the septal flattening in the diastole. Macrorenal side is not visible here, but macrorenal side means it is just reverse of the conventional Takotsubo. That means the base of the right ventricle is not moving, but the apex is moving. It is not very sensitive, but a reasonable specific finding for pulmonary embolism. And if you want to look at the right ventricular contractility, this is called TRAPSE or tricuspid annular plane systolic excursion. Here we put the cursor along the base of the annulus of the tricuspid valve and take the motion mode. We can see there is very small amount of vertical movement that's happening at the annulus. And for the right ventricle, it is the vertical movement of the ventricle that generates the cardiac output rather than the free wall movement. Normal values around 1.5, 1.6 centimeter. Here we can see it is significantly compromised. So and if you can measure the tricuspid regurgitation jet, we can clearly measure the pulmonary pressure. We need to remember that in acute pulmonary embolism, the PA pressure cannot go very high. It is mostly from 40 to 50. It should not go beyond 60 because right ventricle could not handle that amount of high pressure. If there is a PA pressure is more than 55 or 60, we have to consider for a certain chronic component into that. Along with that, what you can expect in lung, obviously this is a perfusion related abnormality. So the lung ultrasound that we are looking for the ventilation related pathology will be reasonably normal. So we'll get an A pattern in the lung with lung sliding and stratosphere sign on M mode. We can look at the lower limb venous Doppler and confirm if there is a deep venous thrombosis present or not. And eventually in this context, we can diagnose a pulmonary embolism in a pericardiac arrest scenario. Next is tension pneumothorax. We all know that for a diagnosis of tension pneumothorax, we have to have a very strong suspicion. But can echocardiography help? Yes, again, there will be an RV dysfunction that you can pick up. May not be like that prominent like a pulmonary embolism, but there will be a significant RV dysfunction. But more important, whenever doing a lung scan, you will find there is A pattern, but no lung sliding. And also there will be absence of B line and lung pulse. When you take M mode through this lung, this is called barcode sign. It indicates that the underlying lung is not moving. There is air, but underlying lung is not moving. It basically indicates there is a separation between the parietal and visceral pleura. And if you're really lucky, we can get a picture like this, which is called lung point. Lung point is the point where the parietal and the visceral pleura has been separated. And one of the last, but not the least, reversible factors in this pericardial scenario is hypovolemia. Now, whenever we are talking about hypovolemia, that means patient has bled. Probably it's a concealed hemorrhage, likely to be a concealed hemorrhage because we are not able to diagnose it. And whenever we are considering for a concealed hemorrhage, it can be either in the thoracic cavity or in the abdominal cavity. And in certain trauma scenario, it can be because of a long bone fracture. Otherwise, there is not much space where patient can have a significant bleed. Also the GI tract, where causing hemodynamic instability without revealing the amount of bleeding. So what is the echocardiographic finding we can expect? We'll get a hyperdynamic LV. There will be an obliteration of the ventricular lumen, as you can see, because the preload is less, the chambers are empty. And this is called kissing sign. That means two walls of the ventricles are coming together and get opposed at the end of systole. We have to differentiate it from a septic heart, because in septic heart, we'll also get a hyperdynamic LV, but the end systolic volume will be there. End systolic volume should not be like that, because the volume status is not so poor. Now, if you look at the IVC diameter should be less with a significant collapsing with inspiration that indicate an empty tank. Now, with our extended focus, we have to see where this patient has bled. We have to look for the thoracic cavity at the two base, and we can look for the effusion. In a trauma scenario, in a situation of bleeding, it will be hemothorax, and also have to do for the fast scan to look for free fluid in the abdomen. Again, in case of trauma scenario, this can be considered as a blood. And at the end, few words about echocardiography as a monitoring tool for CPR. I have discussed few words about it. Mostly we done it, the data has been shown in favor of transesophageal echo because it does not disturb with the chest compression. By TEE, we can direct real-time observation can be done for the compression and relaxation of the cardiac chamber. It has shown that a lot of time there is an improper hand positioning during chest compression, leading to compression on the ascending aorta or aortic root or LV outflow tract, leading to poor outcome. It has shown that it does not interfere with the resuscitation. It gives an objective assessment for the resuscitation quality and giving a better visualization during the ongoing process. And it can also help us to diagnose prognostic factors and the response of the procedure, such as cardioversion, whether the cardiac contractility is getting reversed or not. So to conclude, echocardiography can be considered as an important tool in a peri-arrest scenario. It can contribute in every possible way, like diagnosis, prognosis, and also as a therapeutic role. There is a structured approach that has been developed presently. There are multiple protocols you can follow, whatever suits you. And contrary to the conventional belief, it does not interfere with our resuscitation. So in real scenario, it can really play as a game changer in your clinical management. By this, I'd like to conclude my presentation. Be happy to take questions. Thank you.
So thank you, Sudipta. I think that was a wonderful presentation as usual. Very, very good. And I think it was very informative. I think the role of echoes is actually underrated. I think as we go forward, we'll see more and more people doing echoes. I mean, I think I have a question here from one of the participants, is just saying that if you're finding a Takotsubo syndrome on echo, how do you treat?
Mostly for Takotsubo stress cardiomyopathy, it is a conservative management. If you look at the lab parameters or beyond echo, one echo is very, very classical that you may get a movement, significant contractility at the base, and that there is a decreased contractility at the apex with an apical ballooning. You can get a reverse Takotsubo also in certain situations, though the incidence is less. When you will find the movement is less at the base and more at the apex. It is because of an acute stress leading to down regulation of the adrenergic receptor at the heart. So it's basically a conservative management. You have to continue with the supportive care, maintaining optimum preload and afterload, controlling the heart rate, and maintain a balance between the oxygen consumption and the supply. You have to deal with like a type 2 type of acute coronary syndrome when there is a mismatch between the demand and supply. You will find the tropi is high in this subgroup of patients, depending on the insult, but that does not mean these patients have a need antiplatelet or an enoxaparin for their treatment.
I think you're absolutely right. Takotsubo is actually supportive and more. It's actually a diagnosis of exclusion, because you go and you do an angio and you find that there is no blockages and the coronary is absolutely fine, and you do have your typical LAD territory which starts ballooning. So that's why a lot of people get confused. But you're absolutely right. The treatment is just supportive. There's nothing which you can do, and usually it corrects. I mean, it just takes time. That's the only thing with that. And another useful thing is that when we were talking about management of asthma, one of the things in asthma is to actually rule out pneumothorax in those patients. And I think using the ultrasound and the thoracic ultrasound in those patients could be very, very useful, and to show that, patient doesn't have a pneumothorax. And I think it's something which has to be considered. In the asthma talk, the other thing which I think was very important is recognition that the patient's going to deteriorate, and that is very important. CO2 which is coming towards a normal. So when you do a blood gas in an asthmatic, if it shows a normal PCO2 or the PCO2 is rising, that is when you realize that your patient requires support. Okay, because a patient who actually is a very acute asthmatic will be hyperventilating. So the CO2 is usually low. So a normal to high CO2 should always alert you that the patient is actually getting very tired, and that is where the patient collapses. So echo wise, are there any questions for Sudipta?
Just one point regarding that stress cardiomyopathy or Takotsubo, it is more compared to conventional belief, because when you do a routine echocardiography in a post-operative, major post-operative patient for fluid optimization, lot of time we found there is a small compromise in the left ventricular contractility, which eventually recovered in next 4 or 5 days and become normal like the pre-operative one. We don't do anything, we just control the heart rate, maintain optimal preload and afterload, and most of those patients recover without any extra input.
Yeah. I think the heart rate thing is very important, isn't it? Because they don't tolerate tachycardia very, very well. So you need to make sure that they don't become very tachycardic, because that can cause a problem in those patients. The other thing is that, so is there any tip to understand this pericardial effusion, Sudipta? How do you know that it's a pericardial effusion and not a pleural effusion if you're just doing an echo?
So basically, when you look at, if you take one landmark, it is the descending aorta. If the fluid is collected above the descending aorta in a parasternal long axis view, then it is probably the pericardial fluid. And if it is below the descending aorta, it is probably the pleural fluid. Now, along with that, if the most of the pericardial fluid will start forming from the base, that is the posterior aspect, then gradually it will increase and cover the whole heart. So if you remember that, probably most of the time we can identify the difference between pericardial and pleural effusion.
Yeah. And I think it's very important to point out what you actually said, isn't it? That the echocardiography for a cardiac arrest should be done by a very experienced person, because you need to actually do quite a few echoes before you start doing echoes for echocardiography. Because, for example, the right ventricular pad of fat always resembles like there is a little bit of effusion, but it's not an effusion, it's a pericardial pad of fat. So it's very important to do few echoes before you actually start embarking on doing echoes for cardiac arrest. Excellent presentation, Sudipta. I cannot see any more questions there. So unless the faculty or anyone has any questions. No. So thank you very much for your lecture.
Thank you.
Pleasure as usual. Hope you can stay back for the question answers. We can try answering a few questions at that time. It gives me great pleasure to invite Dr. Suchitra Nikam. She's going to speak on probably one of the most important topics in resuscitation. It's just like, you have resuscitated and the patient comes back. What do you really need to know? Because even if you look at the graphs which I showed you in the beginning, you had a lot of patients who have ROSC, but you do not have a lot of patients leaving the hospital. So from the ROSC to leaving the hospital exactly depends on the care which you can give the patient. And Dr. Nikam, if you want to introduce yourself and share your screen, we can go ahead with your talk, please.
Hello, everyone. I'm Dr. Suchitra Nikam. I'm a freelancer practicing in Pune, humble freelancer, I should say. And I pray to God that such situations of cardiac arrest never arise in a lifetime of a freelancer. But I'm aware that one should know all the recent guidelines. And if unfortunately such an event occurs, then we should be able to treat accordingly. So today I'll be talking about post-resuscitation care. I'll just share my screen. So is it visible? Hello? Yeah. Is the screen visible?
It is, Chitra, it's visible.
Okay. So I'll be dealing with post-resuscitation care. Yeah. And see, return of spontaneous circulation. Just a minute. Return of spontaneous circulation, that is ROSC, after any cardiac arrest is a moment of utmost joy or happiness, such as we feel that the time should freeze. Here, I would like to share a few lines of a poem, just the last stanza of a poem written a couple of years ago. That poem was named, That's the Moment When Time Should Freeze. Sometimes it happens, heart refuses to beat. Sometimes it happens, heart refuses to beat. The monitor beep goes erratic. We go in a desperate feat. The monitor beep goes erratic. We go in a desperate feat. But then a high quality CPR sets the heart on wheels. A high quality CPR sets the heart on wheels. That's the moment when time should freeze. That's the moment when time should freeze. And so to freeze the time, the moment ROSC returns, that is ROS returns after cardiac arrest, the post-resuscitation care should be started immediately, regardless of the location of arrest. Falling out of hospital cardiac arrest, that is
Suchitra,
OSCA.
Suchitra, can you actually start the slideshow so the slides will appear bigger?
Okay, yeah. Just a minute. Is it better now?
Yeah, perfect. Thank you.
Yeah. Following out of hospital cardiac arrest, consider transport to a recognized center of care, like cardiac arrest center of care. Minimum requirements of our cardiac arrest center are 24/7 availability of an on-site coronary angiography laboratory, an emergency department, an intensive care unit, and imaging facilities such as echocardiography, CT, and MRI. Whenever possible, adult patients with non-traumatic out-of-hospital cardiac arrest should be cared for in such cardiac arrest centers. Following in-hospital cardiac arrest, it is easier to start post-resuscitation care immediately after ROS, as patient is already in a hospital and can be shifted to a cardiac arrest center should the need arise. This diagnosis of cardiac arrest is important. It is important to know the diagnosis of the cardiac arrest, because accordingly we can plan the priorities of the investigations in the post-resuscitation care. If there is clinical evidence of myocardial ischemia, like hemodynamic instability, or there is ECG evidence of ischemia, like ST elevation, undertake coronary angiography first. This is followed by CT brain and or CT pulmonary angiography if coronary angiography fails to identify the positive lesion. Early identification of respiratory or neurological cause can be achieved by performing a brain and chest CT scan on hospital admission before or after coronary angiography. In short, it is important to determine the priorities of investigations and accordingly the investigations. This is just a flow chart. I'll come to it step by step. Coming to the airway and breathing. Airway and ventilator support should continue after ROS. Patient who have had brief period of cardiac arrest and an immediate return of cerebral function and are breathing normally may not require tracheal intubation. But they should be given oxygen via face masks if there is the arterial blood oxygen saturation is less than 94%. Patients who remain comatose after ROS or who have another clinical indication for sedation and mechanical ventilation should have their trachea intubated, if not done already during CPR. Tracheal intubation should be performed only by experienced operators who have high success rate. This is very important. Correct placement of tracheal tube must be confirmed with waveform capnography. In the absence of experienced personnel, consider use of supraglottic airway or maintain airway with the basic techniques. After ROS, use 100% inspire oxygen until the arterial oxygen saturation or the partial pressure of arterial oxygen can be measured reliably. Once SpO2 can be measured reliably or arterial blood gas values are obtained, titrate the inspired oxygen to achieve an arterial oxygen saturation of 94 to 98% or arterial partial pressure of oxygen of 10 to 13 kPa or 75 millimeter or 200 millimeters of mercury. Avoid hypoxemia following ROS, that is less than 8 kPa or 60 millimeters of mercury. Then avoid hyperoxemia also. Obtain an arterial blood gas. Obtain an arterial blood gas and use end-tidal carbon dioxide in mechanically ventilated patients. Adjust the ventilation to target a normal arterial pressure of carbon dioxide, that is PaCO2 of 35 to 45 millimeters of mercury. Then in patients, monitor PaCO2 frequently with targeted temperature management, that is TTM, as there are chances of hypocapnia with a TTM. Use uniform approach for measuring blood gas values. That is, if we are using a TTM, then the blood gases value should be obtained when the temperature is kept at that particular constant. Use lung protector ventilation strategy, aiming for tidal volume of 6 to 8 milliliters per kg of ideal body weight. Coming to circulation, in cardiac arrest of suspected cardiac origin, that is, when there is ST elevation on ECG, emergent cardiac catheterization laboratory evaluation and immediate PCI, if required, should be performed. That is, percutaneous intervention should be performed. In patients with ROS after OSCA, that is out of hospital cardiac arrest, without ST elevation on ECG, consider emergent cardiac catheterization only if there is an estimated high probability of coronary occlusion. We can suspect it if there is hemodynamic or electrical instability. There should be, all patients should be monitored with an arterial line for continuous blood pressure measurement, and then monitor cardiac output in hemodynamically unstable patients. Try to monitor the cardiac output in hemodynamically unstable patients. Perform early, that is, as soon as possible, echocardiography in all patients to detect any underlying cardiac pathology and to quantify the degree of myocardial dysfunction. Already the echocardiography has been nicely covered by Sudipta. Then avoid hypotension, that is less than 65 millimeters of mercury systolic BP, and target the mean arterial pressure, such as to achieve the adequate urine output, that is more than 0.5 ml per kg per hour, or normal or decreasing lactate on blood gas. During TTM, that is at 33 degrees centigrade, bradycardia may be left untreated because if blood pressure, lactates, SCVO2 or SVO2, that is either the central or peripheral venous oxygen concentration saturation is adequate. So if not, then consider increasing the target temperature, but it should not be no higher than 36 degrees centigrade. Maintain perfusion with crystalloids, noradrenaline, and or dobutamine, depending upon individual patient need or intravascular volume, degree of constriction, and ionotropy. Do not give, it is just the flow diagram, which is indicating the ventilation and oxygen strategies. Yeah, do not give steroids routinely. Avoid hypokalemia, because hypokalemia can lead to ventricular arrhythmias. Then consider mechanical circulatory support, such as intra-aortic balloon pump, left ventricular. Just sorry, I'll drink some water. Yeah, consider mechanical circulatory support, such as intra-aortic balloon pump, left ventricular assist device, or arteriovenous extracorporeal membrane oxygenation for persisting cardiogenic shock from left ventricular failure if treatment with fluid resuscitation, inotropes, and vasoactive drugs is insufficient. Left ventricular assist device or arteriovenous extracorporeal membrane oxygenation should also be considered on if a hemodynamically unstable patient is there with acute coronary syndrome and recurrent ventricular tachycardia or ventricular fibrillation persists despite optimal therapy. This is just the flow diagram. Coming to disability optimizing neurological recovery. In this, first, we should consider control of seizures. Use electroencephalography, that is EEG, to diagnose electrographic seizures in patients with clinical convulsions and to monitor the treatment, the effect of the treatment. Then bring to control the drug of choice to control the seizures is levetiracetam or sodium valproate as first line of antiepileptic drugs in addition to the sedative drugs. Routine seizure prophylaxis is not advocated post cardiac arrest in all post cardiac arrest patients. Targeted temperature control, this is very important. Targeted temperature management that should be used for adults after either OSCA or ISCA with any initial rhythm who remain unresponsive after ROS. Maintain a target temperature at a constant value, that is between 32 degrees centigrade and 36 degrees centigrade for at least 24 hours. Avoid fever, that is pyrexia, that is more than 37.7 degrees centigrade temperature for at least 72 hours after ROS in patients who remain comatose. Avoid pre-hospital intravenous fluids to maintain the hypothermia. They are not recommended. Coming to general intensive care management, always use short-acting sedatives or opioids because otherwise they may confound our clinical judgment. Then avoid neuromuscular blocking drugs routinely only if during TTM there is shivering, then only we can, which is not controlled by any other thing, then only we can think of using neuromuscular blocking drugs. Then provide stress ulcer prophylaxis with either proton pump inhibitors and or H2 blockers. Provide routinely, then provide deep venous thrombosis prophylaxis routinely. Target blood glucose levels. This is also very important. Target blood glucose levels to approximately 140 to 180 milligram per deciliter, using an infusion of insulin if required. Avoid hypoglycemia at any cost, that is less than 70 millimeters of deciliter. Avoid hypoglycemia. Then the levels of less than 70 milligrams per deciliter. Start enteral feeding at low rates, that's trophic feeding, during targeted temperature management, and increase if we are increasing the temperature. But at any case, avoid going above 36 degrees centigrade. Avoid routine use of prophylactic antibiotics unless there is some specific need like septicemic shock. Coming to prognostication, the general guidelines are in patients who are comatose after resuscitation from cardiac arrest, neurological prognostication should be performed using clinical examination, electrophysiology, biomarkers, and imaging to both inform the patient's relatives and to help the clinicians to target treatments based on the patient's chances of achieving a neurological meaningful recovery. One should know that no single predictor is 100% accurate. Therefore, a multimodal neuroprognostication strategy is recommended. When predicting poor neurological outcome, a high specificity and precision are desirable to avoid falsely pessimistic prediction. The clinical neurological examination is central. It is very important in prognostication. To avoid falsely pessimistic predictions, clinicians should avoid potentially confounding factors from sedatives and other drugs that may confound the results of the tests. When patients are treated with TTM, daily clinical examination is advocated, but final prognostic assessment should be undertaken only after rewarming is done. This is just a flow chart. Clinicians should be aware of the risk of the self-fulfilling prophecy bias occurring when the results of an index test predicting poor outcome is used for treatment decisions, especially regarding life-sustaining therapies. Tests for neurological prognostications are aimed of assessing the severity of hypoxic ischemic brain injury. The neurological prognosis is one of the several aspects to consider in discussing around an individual's potential for recovery. In this, multimodal prognostication comes handy. Coming into multimodal prognostication, start the prognostication assessment with an accurate clinical examination to be performed only after major confounders have been excluded. The major confounders can be residual sedation or hypothermia. In a comatose patient with M less than 3 or less than or equal to 3 at more than or equal to 72 hours from ROS, in the absence of confounders, poor outcome is likely when 2 or more of the following predictors are present. When there is no pupillary or corneal reflex at more than or equal to 72 hours, when there is bilaterally absent N2O somatosensory evoked potential, that is SSEP, wave at more than or equal to 24 hours, if there is highly myelin EEG at more than 24 hours, the neuron-specific enolase, that is, if it is more than 60 micrograms per liter at 48 hours and or 72 hours, if there is status myoclonus with less than or equal to 72 hours, and if there is a diffuse and extensive anoxic injury on brain, CT or MRI. So out of these, at least 2 predictors should be present to convey the poor outcome. Most of these signs can be recorded before 72 hours from ROS. However, the results can be evaluated only at the time of clinical prognostic assessment. Withdrawal of life-sustaining therapy. Withdrawal of life-sustaining therapy, that is WLST decisions, should consider aspects other than brain injury, such as age, comorbidities, general organ function, and patient's preferences. Allocate sufficient time for communication around the level of treatment decision within your team as well as with the relatives. The long-term outcome after cardiac arrest. Perform functional assessment of physical and non-physical impairments before discharge from the hospital to identify early rehabilitation needs and, if necessary, refer to rehabilitation. Organize follow-up for all cardiac arrest survivals within 3 months after hospital discharge, including screening for cognitive problems, screening for emotional problems and fatigue, and providing information and support for survivals and the family members. The organ dysfunction will be dealt with my colleague, Uma. So I will not be going into details of that. So these are the 5 top messages which we should consider after for the post-resuscitation care, which are given in the chart. I need not go into those again. But consider the ABC. The target values of the ventilation and breathing and circulation should be maintained. Emergent cardiac catheterization and immediate PCI after cardiac arrest of suspected cardiac origin and ST elevation on the ECG should be done. Use targeted temperature management either after OSCA or ISCA with any initial rhythm who remain unresponsive after ROS. Use multimodal neurological prognostication using clinical examination, electrophysiology, biomarkers, and imaging, and assess physical and non-physical impairments before and after discharge from the hospital, and refer to rehabilitation if necessary. Thank you. That I acknowledge this to European Resuscitation Council and European Society of Intensive Care Medicine Guidelines 2021. Thank you very much.
Thank you, Suchitra. Very well done. Excellent talk. And I think a lot of information there, which is actually very pertinent and very useful. I think it's quite important to actually mention, how to take care of a post-arrest patient, because you might do the best resuscitation, but if it's not continued in the post-operative period in an intensive care, then usually the outcomes are poor. The temperature wise, I think there's a little bit more evidence now that you don't have to go up to 32 degrees. We generally say that don't allow the patient to get hot. That's it. So any between 34 to 36 is fine. If you want to do a targeted temperature control, or just make sure that they don't get a fever. So you actually actively cool them if the temperature goes above 37. So that is the current thing. I don't have any other questions from anyone. I'll just look at the YouTube thing. I can't see any more questions there. Anyone else have any comments or want to say anything? Any faculty members? No. Okay. So we'll take the questions at the end when everyone will probably chat a little more. Now, I think I've just slightly switched the talks because I think it probably is very useful to actually go on to the part which you did not cover, which was organ donation and brainstem testing, which is one of the things you do if you're not withdrawing care. So like what you said, within sort of 72 hours, if you find that the patient actually does not have brainstem functioning, then you don't have to actually wait till 72 hours. You can go and do a brainstem test. And I'm sure Uma is going to cover it in great detail. So it gives me great pleasure to welcome Uma. So Uma, if you introduce yourself at the start of your talk, that'll be very great.
Thank you very much, sir. I'm indeed grateful to you for this opportunity. Unfortunately, I'm joining from my son's Zoom account. So it's showing Karthik instead of mine. So it's his laptop which I have borrowed. So just a moment, I'll just share my screen. Are my slides visible, sir? Sir, you're muted.
Perfect.
Okay.
Yes.
Thank you so much. I'm indeed grateful to the organizing team and Dheeraj sir and Shiv sir and Dr. Irene and all my team members for this great opportunity to present a talk on brainstem death testing and organ donation for the resuscitation course. It is very important to understand that the concept of brainstem death and its testing and its extrapolation to organ donation and other aspects of care of the donor and the recipient have changed and been modified and upgraded in the recent past in several ways to make way for a lot of things, including diagnosis of brainstem death and for organ donation. So brainstem, let us first understand what is brainstem and why brainstem death is important for us to validate and diagnose before discussing other aspects of organ donation. So brainstem is a very vital structure which connects the cerebrum of the brain to the spinal cord and cerebellum. So it is the most vital structure of the brain, which has three important parts: the midbrain, the pons, and the medulla. And it controls all the important functions of life, like breathing, consciousness, the hemodynamic profile, the blood pressure and heart rate, and even sleep and other functions of the body as well. And hence, any abnormality or any dysfunction of the brainstem is going to affect the entire life of the patient and may result in his death. And out of the 12 cranial nerves, 10 of them, they arise from the cranial nerve nuclei. This is actually one of the aspects which is useful for us during testing. The most important brainstem tracts which are also there and they may be tested include the reticular formation, the motor, and the sensory tracts. I will not go into the detailed anatomical description of the brainstem, but yes, it is important to understand that any affection of the brainstem is going to affect the vital functions of life. There are various definitions of death, and the Academy of the Medical Colleges Working Party defined the brainstem death as the irreversible loss of capacity for gaining consciousness and the capacity to spontaneously breathe. So this is a definition I'm sure any person can understand. It went on to get refined in the due course of time. And there was this term which was known as coma de passe, which meant a state beyond coma for brain death. But yes, remember that coma is not synonymous with brain death. Persistent vegetative state is basically loss of only cortical functions with intact brainstem functions, and this person is not considered to be dead. Brainstem death is the ultimate form of death, wherein absent brainstem reflexes are there, but the presence of a few cortical as well as hypothalamic integrity, such as osmoregulatory functions, may be persistent. Whole brain death means biological death with absent cortical as well as brainstem functions. And death is again the whole brain death along with cardiopulmonary arrest. So there are these definitions, confusing definitions of death, and hence a lot of work has been done to simplify the process. Causes of brainstem death are many, but the most important cause, especially in the current scenario, is the severe road traffic accident or any form of injury to the severe head injury or traumatic brain injury, which results in severe brainstem injury. Then severe CNS infections and encephalitis, brainstem hemorrhage or stroke, brain tumors, cardiac arrest due to any cause, or hypoxic insults which affect the brainstem, all these and poisonings, all these can affect the brainstem and cause brainstem death. There are several prerequisites before we pronounce a patient as brainstem dead. The most important one is irreversibility. That means the procedure or the process which is happening in the patient is irreversible with no possibility of recovery, regardless of any amount of intervention or life support being given to the patient. There is a proper evidence or etiology to the coma which the patient is suffering from, and the confounding variables are excluded in the form of exclusion of severe metabolic, endocrinologic, and arterial blood gas derangements. Drug, if there is suspicion of drug intoxication, you should wait for 5 half-lives of drug clearance before embarking upon diagnosis of brainstem death with proper adjustments to the patient's renal and hepatic functions. Core body temperature should be more than 36 degrees Celsius for 24 to 72 hours, and you may resort to warming to achieve normothermia before diagnosing brainstem death. The systolic blood pressure has to be kept more than or equal to 100 mmHg with or without inotropic or vasopressor support. This is mandatory because, as you will see in the next few slides, when we embark upon testing for a brainstem, especially during apnea testing, one must ensure that the patient is hemodynamically stable and the blood pressure is always more than 90 to 100 mmHg with or without these external vasopressor or inotropic supports. There should be no electrolyte abnormalities. The serum osmolarity, the calcium levels, the sodium levels should be normal. The patient should not suffer from hypoglycemia, and the pH should be more than 7.2. And of course, the alcohol levels also have to be tested if the patient is known to be an alcoholic. So let us come to the definition of brain death or brainstem death. A person, this is basically a simple definition which anyone can understand. A person on an artificial life support machine who no longer has any brain functions and will not regain consciousness or breathe without support. So this is basically how you will explain the relative of the patient about this particular condition. It is the result of an acute catastrophic brain injury or insult, and there is abrupt loss of cerebral perfusion with concomitant elevation of intracranial pressure. And when it becomes more than the mean arterial pressure, then it results in what is known as irreversible damage or brainstem death. So this formula, which is known to everyone, is cerebral perfusion pressure equals to mean arterial pressure minus intracranial pressure, has to be remembered in this scenario. There are 3 tests or 3 examinations which are done to diagnose brainstem death. Number 1 is the physical examination. Number 2 is the apnea test. And number 3 is the ancillary test, which may or may not be done in a particular patient, and they are not essential for confirmation of diagnosis. I will come to it a little later. So brainstem death is a clinical diagnosis made by a certified or a qualified examiner. So the definition of this brainstem death is irreversible loss of entire brain function, including the brainstem, determined by the demonstration of complete loss of consciousness, brainstem reflexes, and the independent capacity of ventilatory drive. That is, the patient must be in apnea with no reversible factors. So let us first come to the first test, or the physical examination, which is done for diagnosis of brainstem death. This is a simple examination wherein there will be no response to pain stimulation, as well as later on when you assess for the brainstem reflexes. There is loss of response to central pain, and the central pain assessment is done by applying noxious stimuli to the supraorbital notch, the angle of the jaw, the upper trapezius, the anterior axillary fold, or the sternum. Neither eye response nor motor response are detectable, and some spinal reflexes may be present even in a patient with brain death and should not be confused with the diagnosis of brainstem death. Now, these spinal reflexes are basically undulating toe flexion response, triple flexion response, plantar response, facial myokymia, Lazarus sign, myoclonus, or muscle fasciculations, and they are in fact very confusing and sometimes may distract the clinician as well as the relatives of the patient from the diagnosis of brainstem death. The various brainstem reflexes which are tested include the examination of the cranial nerves 2, 3, 4, 6. Then basically these are tested by testing of the eyes. If you have loss of pupillary reflex or the light reflex, then more or less brainstem confirmation, brainstem death is confirmed, along with loss of the oculocephalic reflex, loss of corneal reflex. The corneal reflex is tested by a wisp, cotton wisp being applied to the eye and having no corneal reflex. Then the loss of oculovestibular reflex, the caloric test, wherein the ice cold saline is injected into the ear, and it tests the loss of 8th cranial nerve. Then there is loss of gag reflex, testing of the 9th cranial nerve, and for the testing of 10th cranial nerve or vagus, loss of cuff reflex, which is confirmed after tracheal suctioning. So all these brainstem reflexes can be tested. Now coming to the apnea test, which is a very important test which everyone should know, because this is routinely performed, and it is with this that the confirmation of brainstem death is pronounced. It is used to examine the brain's ability to drive the pulmonary function in response to carbon dioxide rise. Everyone knows that once a patient is apneic, the levels of carbon dioxide in the patient's system build up, and they reach a level wherein they can stimulate the respiratory center of a patient who is not dead and cause him to have some amount of respiratory muscle activity or respiratory movements. But in a patient who is brainstem dead, with any amount of carbon dioxide rise, there will be no respiratory movement. But before performing this apnea test, there are several prerequisites. The patient should not be put to any amount of problems. He should be hemodynamically stable. The mechanical ventilator, if he's on ventilation, should be adjusted to obtain a PaCO2 of 35 to 45, and partial pressure of oxygen within the blood, that is PaO2 above 200, with a P of 5 to 8 centimeters of water. And the patient should be given oxygen supplementation during the period of apnea. If the patient is having an endotracheal tube, a cannula can be connected to the endotracheal tube at the rate of 6 liters per minute, and oxygen can be insufflated. And if the patient is having a TPs, then the oxygen flow rate should be 12 liters per minute. Or if the patient can be given a continuous positive airway pressure of 5 to 10 centimeters of water. In the case of loss of respiratory drive, the CO2 is expected to rise 3 to 5 mmHg every minute in the first 2 minutes, and then by 2 mmHg every minute thereafter. And therefore, a particular level of CO2 is obtained at the end of the test, and with no amount of respiratory function at that point in time, the patient can be pronounced as brainstem death. The main aim is to check for the integrity of brainstem respiratory center at high levels of blood CO2. So these prerequisites are very important to remember. The patient must be normothermic. Please remember that do not do this apnea test in a hypothermic patient. The patient must be hemodynamically stable. The blood pressure should be maintained with or without inotropic support. The patient must be free from sedative and paralytic drugs. If they have been used, please wait for 5 half-life cycles to pass before embarking on the test. And the PaO2 should be normal. It should be more than or equal to 200 mmHg after giving 100% oxygen. And the CO2 before starting the test should be in the near normal state. And the ABGs are obtained after 8 to 10 minutes of the test. And if the CO2 shows 60 mmHg or a rise of CO2 by more than 20 mmHg above the baseline, is consistent with brain death. Now, these values have to be, remembered, because they are very important for documentation and for further organ donation and other aspects in that patient. If the patient develops hypotension, then or any cardiac arrhythmias, or if the patient develops desaturation of less than or equal to 85% for more than 30 seconds, the test must be terminated then and there, and ABG should be drawn. Then a separate time and opportunity should be taken for doing the test again after stabilizing the patient. If nowadays most of these critically ill patients are put on ECMO, and if you have to do a brainstem death test on them, the oxygenation can be maintained while doing the apnea test by decreasing the gas feed flow and by using an oxygenation source through the endotracheal tube. Confounding clinical factors which can invalidate the apnea test, as I told you previously, are hypoxia, hypotension, hypothermia, cervical cord injuries, and hypercarbia. Severe hypercarbia can cause cerebral vasodilation. Now, there are several ancillary tests for brainstem death diagnosis. They are useful as adjuncts if there is uncertainty about the diagnosis, or if the apnea test cannot be performed, especially if the patient is a case of COPD with chronic CO2 retention. The test for cessation, there are two tests or ancillary tests. One is testing the cessation of cerebral blood flow, and the other is for testing of electrical activity of the brain. Tests for cessation of cerebral blood flow can be either cerebral angiography, transcranial ultrasound, or computed tomographic brain angiography or MR angiography of the brain. Now, cerebral angiography with the 4-vessel angiography is considered the gold standard, but nowadays transcranial ultrasound is being available in most of the ICUs and it can be used, but it is quite operator dependent and can have several false positives and false negative results, and that can also confirm brain death. Now, radionuclide brain imaging can also be used. But again, another thing is that you can use the loss of bioelectrical activity of the brain with SSEP. The somatosensory evoked potentials can be used. There will be no SSEP potentials in response to bilateral median nerve stimulation, and no brainstem evoked potentials in response to auditory stimulation. So what are the clinical implications of brainstem death? Any qualified, you see, this differs and depends upon the country or the state in which you are practicing. Most states, they can allow a qualified physician to perform brain death examination, while some states, they allow only a neurologist, a neurosurgeon, or an intensivist. And the designation of the brain death in some situations involves an interprofessional team. There is a panel which is constituted, as in India, which consists of the physician, the intensivist, the neurologist, and the neurosurgeon, who can pitch in to confirm the diagnosis of brainstem death. Certification of brain death is generally done after a second apnea testing to be just sure that there are absolutely no chance of reversibility. In UK, a second test can be done at any time after the first when the blood gases are normalized and the patient is hemodynamically stable. In USA, the performance of apnea test after giving appropriate time for confirming the absence of brainstem recovery and the use of only one apnea test is recommended. You see, and this also differs in different states in US. And in India, apnea tests need to be repeated after an interval of 6 hours and to be certified by 4 physicians from a panel. And the time of death is the time of PCO2, is the time when the PCO2 reaches the target value during the second apnea test. Patients who underwent the ancillary test for diagnosis of brain death, death is pronounced when the results are officially reported. So there is a lot of variation in this in various countries, but the essence of it is that no patient should be denied the opportunity to survive. right? So that is what is important. The care should never be suboptimal just because there is a possibility of brain death. That does not justify. But nevertheless, one must understand that there are several red flags. Red flags meaning you need to consider delay in doing the testing for brainstem death, or consider doing an ancillary test in these patients, because there can be several confounding factors, and that can also prove as a risk to the patient per se. These red flags constitute testing for less than 6 hours of loss of last brainstem reflexes, testing for less than 24 hours with anoxic damage etiology if the patient is hypothermic, patients with neuromuscular disease, patients in whom steroids are given in space-occupying lesions, prolonged opioids or fentanyl infusion, brainstem or posterior fossa pathology. Now, these pathologies, you can never be sure that the patient is brainstem dead. Therapeutic decompressive craniectomy, because they also behave in a different way as compared to a patient who is a sure shot diagnosis of brainstem death. Now let's come to organ donation. It is very important to understand that organ procurement can occur only and only after death has been declared. So no discussion about organ donation should be done before declaration of brainstem death or brain death, whatever is prevalent in that particular country. It is a multidisciplinary team which is involved in organ donation for procurement and donation independent of the treating team. The treating team should be absolutely different and not have any connection with the organ procurement team. No patient should experience deprivation, as I told you. Members of organ donation or transplantation team cannot be involved in brainstem death certification. So this is also very important to document that the clinicians who are involved in this are not the same as the clinicians involved in brainstem death certification. The interval observation period of 6 hours is usually sufficient in adults and children more than 1 hour, so more than 1 year. A reliable interval period has not been established in children less than 7 days old or in neonates. And for children between 7 days to 2 months, 2 examinations and EEGs should be separated by at least 48 hours. So we need to be a little more cautious when we are dealing with children in such situations. So there are essentially 3 steps in the diagnosis of brain death. One is establishing the etiology, which has to be irreversible, and excluding possible reversible syndromes mimicking brain death, and demonstrate clinical signs of brain death like coma, brainstem areflexia, and apnea. When planning for organ donation, separate complete examinations by 2 physicians is recommended, and medical documentation should include the etiology and irreversibility of coma to be documented, and all the tests of motor, brainstem reflexes, and apnea tests to be performed and documented, and justification of the confirmatory test to be written in detail. Now, the care during organ donation is multifaceted. It begins with the optimization of the donor following the determination of death, and optimizing the cardiopulmonary status via hemodynamic and ventilatory support. Expeditious organ or tissue procurement is recommended. Now, this is because a cascade of inflammatory mediators are released following brainstem death, which invade almost every solid organ, leading to increased immunogenicity. And sometimes if you harvest these organs and transplant, they can result in acute rejection, and that will be a very futile exercise. And hence, the procurement of the organs should be done as early as possible once the brainstem death has been pronounced and the relatives and the guardians have agreed upon, or if there is an advance directive or will of the patient regarding organ donation. Now, apart from routine support, cardiopulmonary support, and hemodynamic support and ventilatory support, there are several hormones which are given to a patient of brain death for maintaining the hemodynamic profile, for example, vasopressin, insulin, thyroxine, and methylprednisolone. There are specific responsibilities of all the team members involved in organ donation, especially starting from providing education, identification of potential donors and recipients, coordination, support the families during this difficult process, because there are several cultural, psychosocial, and religious barriers which need to be tackled, and administration, management, and interaction with the organ procurement organization of that particular country. Now, the appointment of an organ procurement coordinator is almost mandatory in any center registered for transplantation, and a consent or living will of the patient who has been pronounced as brainstem death has to be obtained and documented. And the coordinator must assure the relatives that the patient will be given full support till the time the diagnosis is made and the donation is finalized. And then he can contact the respective organ donation networks in that particular country for searching the matching recipients. And the first match for each tissue or organ becomes a prime transplant candidate for contact. And the transplant surgeon then makes the final decision based on various factors. And the receiving coordinator also conducts the same kind of an exercise with consent, matching, and other religious and social aspects to be tackled as per the country and the region. And recovery of tissue is performed by the recovery surgeon either in the same hospital or another hospital, depending upon the situation. There are two types of donation. One is a non-living donation and living donation. In a non-living donation, that is what we are dealing with. Donor optimization and other formalities have to be carried out. Standard organ removal in the operating room has to be done. And organ cooling is important to reduce the warm ischemia time. And a thorough organ washout technique with preservatives to decrease the immune reaction and formation of oxygen-free radicals is important. And for the living donation, it can be a directed donation or a non-directed donation. I would not be going into the details of that. There are two types of donors. Basically, one is donor after circulatory arrest or cardiac death, and another is donor after brain death. That is what we have been talking till now. Now, what do you mean by donation after cardiac or circulatory arrest? Organ donation happens after the heart stops beating, in contrast to donation after brain death, where the heart is still beating. So you must understand that in donation after cardiac arrest, the heart is non-functional or not able to pump blood to the organs. So the important point to understand here is organ retrieval has to be done then and there or as soon as possible, preferably within 60 minutes. There are two broad categories as per the modified Maastricht classification, which I'm coming up in the next slide, of non-heart beating donors according to the circumstances of cardiac arrest, uncontrolled and controlled. Now, there are various countries which practice uncontrolled donors and various countries which practice controlled donation. So the different categories are described in the table, which I'll be coming to in the next slide. Categories 1, 2, and 5 describe organ retrieval that follows unexpected and irreversible cardiac arrest or uncontrolled donors donation after circulatory arrest. Uncontrolled DCD basically means which is not in your hands and it has gone out of your control. So it is basically an unexpected cardiac arrest or irreversible cardiac arrest situation wherein the patient has suddenly died, and you have, and if there is a decision regarding organ donation. And categories 3 and 4 refer to retrieval that follows death resulting from planned withdrawal of life-sustaining cardiorespiratory support or controlled donation. Now, this is basically done in several Western countries wherein even euthanasia is legalized. And you know that it is an end-stage terminal illness patient, and there are advanced directives wherein life-sustaining cardiorespiratory support is withdrawn at a particular day or a point in time, and you can plan the organ donation accordingly. So this is the modified Maastricht classification of DCD. And it is important to remember that in case of uncontrolled DCD, the organ transplantation should be done then and there, and the transplant center should be adjacent to the emergency department. And in case of anticipated cardiac arrest or cardiac arrest in a brain dead donor, this is known as controlled DCD. It can be done either in the ICU or the emergency department. Now, coming to this flow chart, basically this what this says that there is, when you make a decision to withdraw invasive treatment, you must understand that first you assess whether the patient is suitable for organ donation, and then only refer the patient to a donor coordinator. Before this exercise, it is a futile aspect. Then consent and authorization as a normal donation is required, and maintenance of complete hemodynamic stability until the treatment withdrawal is done, and treatment withdrawal can be delayed until retrieval team arrives and prepares themselves, and expedited diagnosis of death using circulatory criteria can be done, and transfer to the operation theater for organ retrieval with family briefing, and consent can be done, and team briefing is also important in this particular situation. But in India, this kind of DCD organ donation is still yet to pick up, and laws have to be made for this. Now, coming to donors after brain death, this is recognized as a legal death in India. This is what I was talking about. A brain dead organ donor needs the same intensity of care with focus of treatment directed towards organ perfusion and improved graft quality. And the goals of ventilatory management in a donor who is being taken to the operation theater for harvesting of the organs are to maintain a minimum FiO2 to obtain a PaO2 of more than 100, SpO2 of more than 95, PCO2 between 35 to 40, and pH in the normal range. The circulatory and biochemical variables are managed by the general principles of the rule of 100. So what is the rule of 100? It is very simple. Maintain a target blood pressure of more than 100, urine output of more than 100 ml per hour, hemoglobin of more than 10 or 100 gram per deciliter, PO2 of more than 100 mmHg, and blood sugar target at 100% of normal or more than 100. Now coming to NOTO. What is NOTO? NOTO is National Organ and Tissue Transplantation Organization. It is a very vital organization in India which deals with organ transplant and all the rules and regulations about transplantation. There are various regional and state organizations as well, and this is what is known as National Organ and Tissue Transplant Registry with a transplant coordinator in every hospital which has been registered. It has been amended from time to time. And India is also part of the World Health Organization Global Observatory on Donation and Transplantation. And Constitution of Brain Death Certification Board has been simplified with the amendments. Whenever a neurophysician or neurosurgeon is not available, an anesthetist or intensivist can be a member of the board, subject to the condition that he is not a member of the transplant team. And tissues have also been allowed to be transplanted along with organs, but organ donation is prohibited in mentally challenged patients. Near relative definition has been expanded to include grandchildren and grandparents. So to conclude, brain death is a state of cessation of cerebral function wherein the proximate cause is known and irreversible. The American Association of Neurology has defined brain death with 3 cardinal signs: cessation of functions of brain, including the brain stem, coma or unresponsiveness, and apnea. The first priority is to save the life of the patient and not think about harvesting tissues or organs. And organ donation is not permission to give up or withdraw care. So that is very important to understand. Please follow the local rules and regulations regarding your organ donation. Numerous barriers to organ donation and recovery are there which have to be overcome. Nowadays, a presumptive strategy for counseling of the patient's relative is done in most ICUs because we need to save the people who are dying from various organ failures. Tissues that may be recovered and transplanted include blood vessels, bone, cartilage, corneas, heart valves, skin, and tendons. So we have come a long way from cornea or eye donation, which was first popularized in India by Aishwarya Rai. Organs recovered and transplanted include heart, intestine, kidneys, liver, lung, and pancreas, and many more to come. With advancement in scientific technology and anesthetic management, this has been made possible. I'm indeed thankful to the organizers and to the game faculty, and especially Shiv sir, Guru sir, Dheeraj sir, for this opportunity. This is just a summarization of the donor management, what are parameters which you need to keep in mind, and the specific brainstem tests which you need to do in these patients, and the prerequisites which always have to be remembered for diagnosis of brainstem death. Thank you and Jai Hind. I'll just stop sharing the screen. Yes.
Thank you, Uma. Thank you very much. That was a fantastic talk. You know, it's very difficult and it's actually a very important topic. I think people don't talk about it enough is what, sometimes as an intensivist, we have this ethical consideration of like, oh, do you take a patient who looks like he's got loss of cerebral function and, he's going to die, to someone who's actually sick on the ward and you think, oh, you can save his life. So what people don't realize is if you actually have an organ donor, you are saving at least 5 lives, if not anything else. I mean, there are a lot of lives which are saved with one person. I think my personal experience where one of my nephews actually died and he donated his organ and he was very young. And I think quite a lot of people actually benefited from that. So I think I really commend his parents for taking that decision. It's a very difficult decision. I think India is slightly challenging cultural issues, people believing what will happen when I'm born again, when I give my organs and stuff like that. And things like tissues, bones, corneas, these can be harvested up till 24 hours after you actually die. So there is, tissue donation is something which is equally as important. So if people don't want to donate their organs, raising awareness about tissue donation is very, very important. It's also important, I don't know in India, but in UK, it's like if you actually have brainstem death, you're dead. Even if you have a heart going, you have everything respiratory functioning. As long as you have a brainstem patient, there's no cessation of brainstem death. Function is actually considered as death. So that's why.
Same as in India, sir. Same as in India.
So it's also happened there.
Yeah.
So I think very interesting talk. I'm just going to see if there are any questions regarding this. And I think for the PG point of view, I think this is a question which we
actually
get
very
asked.
Exhaustive. I couldn't cover in 30 minutes a lot of points.
Yeah, no, but I think you did enough. This was very, very comprehensive because it is. I think exam question, it's asked very often in our exams at least. So it's very, very important that people know.
Sure, short theory question in anesthesia.
Yeah, exactly. It's a very important thing. Maybe we didn't have times, otherwise, maybe in the future we can talk about management of maybe in one of the ITU seminars of how to actually manage a patient. What people don't know that these are patients who are considered as ASA 6. Right, so in ASA classifications, they say ASA 1 to 5. An organ donor is an ASA 6 when you anesthetize him. So that's also another point which I'm not sure a lot of people know. There's one question here which actually is saying that what is the sequence of retrieving the organs for donation?
Sir, I did mention in one of my slides, the sequence basically is important to understand because within as early as possible, you need to retrieve. But heart, lungs, kidneys, liver. I mean, this is the basic sequence which we